Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar of AMOGS Emergency Obstetrics Committee with Warangal, Mancherial, Guntur, Kadapa OBGYN societies. It's my privilege to welcome the coordinators of today's webinar, Dr. Niharika ma'am. Ma'am is the Secretary of OGSV from 23 to 24, Consultant Obstetrician and Gynecologist from Birthright by Rainbow Hospitals, Visakhapatnam. I welcome you, ma'am. And our second coordinator and MOC is Dr. Sailaja ma'am. Ma'am is the past treasurer and secretary of Vijayawada OBGYN Society. And ma'am has delivered many lectures at IMA Vijayawada, APCOG, Nellore, and UA Foxy. I welcome you, ma'am, and I hand over the session to you.
Thank you. Thank you, Sahiti. Thank you for handing over. On behalf of AMOGS Emergency Obstetrics Committee, I welcome all of you. We have this webinar in association with Warangal, Mancherial, Guntur, and Kadapa Obstin Gynecologist Societies. So before we proceed with the webinar today, let us invoke the God for their blessings. So can we have the invocation, please?
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam.
Thank you, Sahiti. It is indeed a great pleasure of mine to invite Dr. Sneha Bhuyar. She's been the breast committee chairperson in 2019 to 21 at Foxy and the governing council member of ICOG 21 to 22. She did the AMOGS chairperson of medical obstetrics committee in 22-24, and she is presently the emergency obstetrics committee chairperson at AMOGS. And madam has many awards to her credit. She is an academician par excellence. She's delivered many lectures, orations, and moderated many panels. I welcome you, madam, and I hand over the proceedings to you. Sneha, madam.
Sneha, madam.
I think we lost her.
Yeah.
Yeah, connection.
I'll just call her. Shelja, ma'am, will you call her?
Yeah, I'll call.
Can we have the next slide, Sahiti?
Yes, ma'am.
Let it be on display while madam joins us back.
Neha is there.
I'm here.
Yeah. Yes, ma'am.
Yeah. So a very good evening to one and all. A very good evening to respected chief guest, Madam Shanta Kumari and Madam Prabha Devi as guest of honor for today's program. A very good evening to respected President of AMOGS, Dr. Kiran Kurtakoti, Secretary Dr. Bipin Pandit, and immediate past President of AMOGS, Dr. Pardeshi Sir, the entire team of office bearers of AMOGS. Speakers for today, respected Dr. Murlidhar Pai, speaking on WHO Labour Care Guide, Dr. Sampath Kumari speaking on induction of labor, and I'm sure this will be a very interesting academic session today. So I welcome all the faculties, especially Dr. Purushottam, President of Warangal, dear friend Dr. Aruna Suman, the past Joint Secretary of Foxy, Dr. Uma Shankar, Secretary Guntur, Dr. Swarupa Rani, President Mancherial, Dr. Venkateshwar Rao, President of Guntur, Dr. Sandhya Rani, the past Secretary of Warangal, all the esteemed panelists for today's panel discussion, which I will be moderating on labor emergencies, Dr. Deepika, Dr. Manasa, Dr. Pratibha, Dr. Harsha, Dr. Anita, Dr. Lakshmi, and of course, my right and left hands, Dr. Sailaja and Dr. Niharika. I welcome all of you here for this program. and very thankful to all the presidents and secretaries of all these 4 societies, the Warangal, Mancherial, Guntur and Kadapa societies. And I take this opportunity to thank all of you at this moment. It is my pride and privilege to introduce today's chief guest, Madam Shanta Kumari. Has she joined, Aruna? Has Madam joined? Otherwise, we start
No,
with...
no. I think she'll take some time. She's in the other meeting.
So, can you display the CV of Dr. Kiran Kurtakoti Saiti? I welcome our AMOGS President, Dr. Kiran Kurtakoti, a good dear friend as well, who is the ex-committee chairperson for FOXY, and of course...
that's fine. Sneha,
Yes.
that's fine. That's
Yes,
fine.
yes.
Thank you. Thank you.
Yes,
Thank you.
without wasting much time,
Yes.
we would like to hear from you,
Yes.
Kiran.
Well, first of all, congratulations, Sneha. Why I am saying congratulations? Because you are taking AMOGS to a next level. You have associated all the AP societies, and I would like to appreciate and acknowledge all the presidents and secretaries of Warangal, Mancherial, Guntur, and Kadapa OBGY societies. So you have AP and probably Karnataka societies also with you now. So thank you so much, these societies, for being associated with AMOGS. I also acknowledge the presence of Dr. Prabha Devi, already guest of honor, and Dr. Pardesi, who is the past president, Dr. Aruna, Dr. Shailaja, Dr. Harsha, and of course, Dr. Murlidhar Pai. Murlidhar Pai is one of the most sought after speakers. I hope, Murlidhar, you have finished the previous talk on PPH, because
I just jumped the queue there.
Yes.
Because the previous speaker had a technical difficulty. I took the opportunity and jumped the queue.
Good. So thank you again for being on the AMOGS platform again. Huh? So I think, Murlidhar, you should shift now to Maharashtra. Tell that Sikkim Manipal society to have a society or college in Maharashtra. So really,
Sure.
we are brought in Maharashtra again. So thank you so much. Thank you overall. Excellent program. And Sneha, you are doing a fantastic job. Last 2 years, you have been doing fantastic job, and I'm sure during my tenure, you will be doing equally great job. And we hope, wish and pray that AMOGS sees you at the highest position again this year. So all the very best to you. Best wishes from my behalf to this webinar and the program. Thank you so much.
Thank you so much, Dr. Kiran. Indeed, it is precious from your side. May I have Saiti? Can I have Dr. Pardesi sir's CV? All of you know by this time our very popular president of AMOGS, Dr. Pardesi sir, who is a past vice president of FOXY. And of course, he has many awards and accolades to his credit. But I would just like to say that sir is our mentor, and he has literally handhold us towards the way of FOXY. So with all these awards and accolades, I would just like to introduce you, and we would like to hear from you, sir. Over to you, Dr. Pardesi, sir. Sir, please unmute.
Good evening, all. Respected Chief Guest Dr. Shanta Kumari, respected guest of honors Dr. Prabha Devi, and our AMOGS President Dr. Kiran Kurtakoti, Madhuri Patel ma'am. So first, I wish to congratulate Dr. Sneha Bhoyar, our ever active, ever smiling chairperson of AMOGS, and with all the Warangal, Mancherial, Guntur and Kadapa societies for organizing this webinar, which is useful in our day-to-day practice. That's webinar on labor. So just I wish to add that our Maharashtra maternal mortality rate is 33. And we are proud of this AMOGsians. Due to the efforts of this AMOGsians, we could achieve this. And with the able leadership of Dr. Kiran Kurtakoti, I think we will achieve this single-digit MMR in future. And with the eminent faculty like Dr. Murlidhar Pai, I had in the last webinar also at 5 o'clock, Dr. Sampath Kumari, Dr. Sneha Bhoyar, and Chairperson Dr. Purushottam, Dr. Aruna Suman, Dr. Uma Shankar, Dr. Sandhya Rani, Dr. Anita, Dr. Harsha, Dr. Neharika, and all others. I think this is going to be a great event. I wish every success to Dr. Sneha Bhoyar for her future endeavor in FOXY in vice presidential election. And I think Aruna Suman is there. I wish every success to Dr. Aruna Suman for her future endeavor in FOXY as chairperson. Wishing
Thank you,
every
sir. Thank
success
you. I need your blessings. Thank you.
wishing every success to this webinar. Thank you. Thank you so much for inviting me.
Thank you, sir. Thank you so much for all your blessings and best wishes. And I think I still cannot see Madam Shanta Kumari. So we would go ahead for
Dr. Sneha, Dr.
Yes.
Sneha, actually,
Yes.
madam is joining. I'm sending her the link now.
I got it. Yes. So by the time we can
Madam has
have-
joined. Madam has joined.
Madam has joined. Okay. Very good evening, Madam Shanta Kumari. Welcome. And without spending much time, I would just say that Madam's CV is such highly decorated CV, and Madam is such a genuine person, inclusive of everybody. I would just say she's a rock solid support for the aspiring people like me, whoever is hardworking. Just need your support, Madam. I'm over to you for your precious word. So I think you can stop share.
Good evening, everyone. Yeah. Neha, honestly, I won't agree with many of the things because I was fighting with you so much for not joining the webinar. I understand.
I know that.
Good evening, everyone. I see what happens is I think now we have moved from the online to physical platform. I'm finding the physical platform only good as usual. I can see Murli sir smiling away and so many colleagues who are there. All Rajendra Singh Pardesi and all our lot of AP Telangana people are there. I can see Shailaja and all. So good evening, everyone. Sneha, what I would like to tell is one line is, you come from a very, very small society. I have visited Yavatmal. It's such a small place, and it's really far away and not a big city and all. See, in spite of coming from a small society, you have been working very hard to take part in all Foxy activities. Yeah, now I can see Kiran. Hi, Kiran. And that shows your interest for the organization and the academics. I really appreciate that because I have visited Yavatmal, I know, so I used to always appreciate Sneha and Girish coming from a small society and going all out and becoming a part of Foxy, becoming the chairpersons and all. So the and the breast committee, as the breast committee chairperson, you have really worked very hard to see that the committee activities are taken forward even during the pandemic and before and after the pandemic also. So very well done. I wish you all the best. And I would like to again congratulate Kiran for taking over as the president of AMOGS with Dr. Pardesi. And of course, we have my teacher, Murli sir, who is there. So wish you and the whole webinar all the best. Sampath has also joined, I can see. So it is, I think, AP Hyderabad and AP Telangana societies. And I'm glad that many societies have come together. Now, let me make a frank, honest statement on this platform. A lot of AMOGS people is there. The past president of AMOGS is there. The present president of AMOGS is here, and maybe some future presidents of AMOGS are also there. Remember, I am very fond of AMOGS society because we started our societies looking at you all, the way you all have brought together all the societies together. But at the same time, let me tell you, we have to be very inclusive. You remember, AMOGS is only a part of the whole big arena of Foxy. You have to live and let live. You have to allow the other societies people also to come up and become the chairpersons of Foxy. This is very important. Inclusiveness. This is what I will hold people like Rajendra Singh Pardesi and Dr. Kiran Kuttukoti responsible for keeping everyone together. Don't drive things to make people go away from the organization. So keeping people together is very important. So we look forward for your participation in that and see that you support some of the South societies also. I'm not telling you as a South person. I'm telling you only as a Foxy past president. For me, all the societies are same. But there are inhibitions for people from some societies. Small societies. See, we have seen how you all have supported people like people from the small societies. So now, being seniors, your responsibility is to support the other small societies also, which have actually taken inspiration from AMOGS.
Done.
Okay.
I give you my word for that, Shanta.
Thank you, Kiran. And let us not be very binocular. Like Foxy is a whole federation. There's no difference between AMOGS and TCOGS and APCOG or Tamil Nadu. We are all one. This is my message which I would like to give to all of you.
Thank you.
Okay, thank you all.
Thank you so much, madam. You know that you don't praise anybody without any reason, and I do the same thing. I agree with everything, whatever you have said, and definitely our vision should be global and not a very narrow-minded thinking. Hardworking people should be supported. I fully agree with you, but whatever
Yes.
the reason may be. Thank you so much, madam, for your prestigious message and best wishes as well. Thank you so much. And I would like to thank all of you once again for accepting our invitation and of course being here on this platform. So I would take this opportunity to introduce the teacher of teachers, Madam K. Prabhadevi, who is the former professor and head of the Department of Obs-Gynae, NRI Medical College and General Hospital, the Chinakankni. So madam has worked in all the capacities and her CV is such highly decorated and such an illustrious person she is. So I think it's better that we listen to her precious words. So over to you, madam, for your blessings and wishes.
Thank you, madam.
Right.
Am I audible? Yes.
Yes, ma'am.
Yes, ma'am.
Yes, madam, you are audible.
Very good evening to all of you. Just now we heard about our societies of Vijayawada. It was very much uplifted under the past president of Dr. Shanta Kumari. Very much uplifted with the help of our secretary, past secretaries, past presidents, Dr. Suchila, Dr. Sailaja and all. So respected Madam Dr. Shanta Kumari, Dr. Sneha Bhuiar, Chairperson, AMOGS, Chairperson for Emergency Obstetric Committee 2024-26. I came to know Dr. Sneha from 2019 onwards as Foxy Chairperson, Breast Committee. When I used to hear so many webinars during COVID, I attended this Breast Committee meetings so many times. They were very impressive and very knowledgeable. Dr. Kiran, President, Dr. Bipin Pandit, Secretary General, Dr. Rajendra Singh, IPP, Dr. Madhuri Mahendel, Treasurer of AMOGS. Today's great speakers, Dr. Muralidhar Pai, Dr. Sampath Kumari, Dr. Sneha, the moderator of today's panel discussion. Very important topic of labor emergencies. So, respective chairpersons from both Telangana and Andhra Pradesh, panelists, and out of so many panelists, I know Venkateshwar Rao Garu, Uma Shankar, and other chairpersons, Aruna, the Andhra and Telangana societies. Dr. Niharika from Visakhapatnam, Dr. Sailaja, our close friend, very vibrant past secretary of our Vijayawada society, and she is awardee of WA under the leadership of Shanta Kumari. Very, very good evening to all of you. At the outset, I congratulate and appreciate Dr. Sneha Bhuiar for her dedication and commitment as a chairperson in all many committees. I also thank Dr. Sneha and Sailaja, coordinator, for having invited me as guest lecturer. I heard so many series of webinars by Dr. Muralidhar Pai. They are well taken by postgraduates and faculty all over the nation. So many series of webinars they are released every week. So we used to hear and felt very happy. They are very crypt within half an hour. The topic of WHO Labor Care Guide, very recently introduced, very simple, but not yet implemented in so many medical colleges and outside. Even for me as head of the department, I worked in different colleges and I used to tell postgraduates, they are very much reluctant to even draw the old WHO modified partogram, which is very, very simple. So I hope by hearing his useful topic, most of the people get benefited and start doing practice at least. Coming to induction of labor is very good olden topic, but lot of obstetricians go into trouble because not following correct guidelines. And I feel the topic definitely makes a recap for practicing obstetricians. The last and most important topic, that is panel discussion on labor emergencies. Sneha being the moderator with the panelists, definitely we have little guidance how to manage all these emergencies, and a good take-home message will be taken. I wish that this webinar is going to be more useful and give good take-home message to all obstetricians and including postgraduates. So wishing you all the best. I wish Dr. Sneha very good luck for the post of Vice President, Foxy. She is very capable and worthy candidate for the same. We all members of societies definitely bless you for the candidature of the Vice President. Thank you very much for giving me this opportunity as guest of honor. Thank you, very nice of you. Thank you very much.
Thank you so much, respected madam, for your blessings. And thank you so much for all the love and affection.
Dr. Aruna is also contesting. Which web?
Namaste, madam. Sampath Kumari, madam.
Yes.
You have come to our Vijayawada Society.
Once again, all the dignitaries, Madam Shanta Kumari and Madam K. Prabhadevi, and thank you so much all the AMOGS office bearer, especially President AMOGS, Dr. Kiran Kurtakoti, and respect to all the faculties for today's and all the esteemed panelists and chairpersons as well. I declare that the inauguration is over and we can proceed with the academic session. Thank you so much once again, all of you. Thank you. Over
Thank
to
you,
you,
madam. Good evening to all of you. And at the outset, let me thank Dr. Sneha Bhuyar, madam, for giving me the opportunity to be one of the coordinators for this session. We are going ahead with session 1, that is normal labor, WHO labor care guide. Can we have the CVs of our chairpersons, please? Dr. Purushottam is President Warangal OBGYN Society, working as Associate Professor at RVM Medical College, Siddipet. Has been the Joint Secretary of Telangana TCOG. Next slide, please. Dr. Aruna Suman doesn't need any introduction. She was our Joint Secretary Foxy 2021 and the Organizing Secretary of AICOG Hyderabad 2024. She is the National Coordinator No to Walk Committee, working as Professor OBGYN and HOD Government Medical College, Jagityal. She was a member of Practical Obstetrics Committee, Foxy, and she has been the
Thank you, Dr. Shailaja. Thank you. Let us
she has
continue.
many
But I think Shailaja, I would like to add, Aruna Suman is contesting for the post of Chairperson of Practical Obstetrics Committee.
All the best to
Aruna
Aruna Suman, madam. All the best to her.
Thank you so
much. Next is Dr. Uma Shankar Garu. He is the Secretary, Guntur OBGYN Society. He is the Clinical Head and Infertility Specialist at Ahalya Hospital, Guntur and Vijayawada branches. He has many awards to his credit. I hand over to the chairpersons for the session 1. Purushottam sir has joined, madam.
Okay, let me introduce, sir. It's my privilege and honor to introduce Professor Dr. Muralidhar Pai, sir. He's a teacher of teachers and he's a very good academician. One confession I would like to make, sir. Whenever I take a class for PGs or undergraduates, definitely I will listen to your YouTube channel and then only go present. I take many points from your presentation when I do any presentations. Thank you so much, sir. And he's a Dean, Sikkim Manipal Institute of Medical Sciences and Professor of OPG, 36 years of academics, 20 awards, 15 international fellowships, 207 publications, 2 textbooks, 772 guest lectures. I welcome you, sir. And it's our honor today that you are with us.
Yeah, thank you. Yeah. Yeah. First of all, I would like to bring you all greetings from SMIMS. Please visit Sikkim. Secondly, I am really thankful to Dr. Sneha. And when she invited me, I could not say no, though I had one more lecture at the same AMOGS in another webinar. But I always have time and, my efforts are there for attending webinar of Dr. Sneha because I found her to be extremely industrious. She works very hard. She's very humble. And I thought last year itself she would become the vice president. But usually people stop doing things once they lose. But she has continued with working more hard. And I sincerely wish you, Dr. Sneha, this time you will definitely become vice president. Secondly, I wish Aruna all the best. She's another person who works very hard. And I have seen her for long working along the side of Dr. Shantakumari. And she definitely deserves this particular position and more. Now I come to today's chief guest, Dr. Shantakumari, I should say my leader. She was my student. She always respects saying that I am her teacher, but I respect her as a leader because she's definitely, as she expressed, she always looks at a global picture. She is not looking at the smaller issues. She wants the larger betterment of the women at large and also every practicing doctor. And Dr. Prabha Devi, I'm really fortunate to have her as one of the guests of honors. She's the real teacher of teachers here today. And there are so many other good friends, Dr. Kiran, Dr. Pardesi, and others. Thank you very much for your love, because of which I get encouraged to make my lectures and topics better and better by the day. This particular topic, WHO Labor Care Guide, as Madam said, it was released in 2020 itself, but it has not somehow become popular because it coincided with the COVID probably. I gave this lecture for the first time in Hyderabad during Dr. Shanta Kumari's organized Foxy Figo conference. And none other than the person who was very much involved in bringing this labor care guide, Professor Sir Arul Kumaran, was there. And at the end of the lecture, he said, Murli, you have brought this out much better than what we conceived. And that was definitely a good compliment, I would consider. And before I start this lecture, what I want to tell you is that this is not drastically different from the previous partograms, but it's only an improved version, I should say. There are certain things which we may feel that it is controversial or not acceptable, but if you really carefully read, then you understand what is the thought behind whatever they have said. So the labor care guide is a tool, something like a partogram in the past, that aims to support good quality, evidence-based, respectful care during labor and childbirth. Irrespective of the setting, it can be at level 1, level 2, level 3 healthcare hospitals for a positive childbirth experience. Well, there are so many beautiful words here, but the labor care guide intends to achieve each single word. So we can definitely call it the next generation partograph. The recommendations include 26 new recommendations. It has not discarded the old ones. The 30 existing recommendations, that is from the old partograph, are still being continued. From labor through to the immediate postnatal period. If you recall, the previous partograms ended at the second stage. They, in fact, didn't cover properly the second stage of labor, definitely not the third stage and postnatal period. But this labor care guide intends to address second stage as well as third stage and postnatal period. The guiding principles are labor and childbirth should be individualized and women-centered. No intervention should be implemented without a clear medical indication. That means unnecessary inductions, unnecessary cesarean sections should not be done. At the same time, if it is indicated, they should not hesitate to do that. Only interventions that serve an immediate purpose and proven to be beneficial should be promoted. So I can summarize the guiding principle as a clear objective that a positive childbirth experience for the woman and newborn and her family should be at the forefront of labor and childbirth care at all times. What are the aims? Of course, the principles always dictate the aims. It is to guide the monitoring and documentation of well-being of women and babies and the progress of labor. We all know that we have to monitor the labor and we have to document it. But how to monitor, how often to monitor, and how to document is what is told in this labor care guide. It also guides health personnels to offer supportive care throughout the labor and ensure positive childbirth experience for women. It prevents unnecessary use of interventions in labor, and it supports audit and quality improvement of labor management. So the document can be audited and you can have quality improvement suggestions after that. It assists health personnel to promptly identify and address emerging labor complications. So when you monitor, if you cannot handle or if you identify a problem, you should also know how to refer and when to refer to a higher center in time so that there will be a positive childbirth experience. By providing reference thresholds for labor observations. This is the most important part of this labor care guide. Reference thresholds, when you have to refer. That is the most important point. And that are intended to trigger reflection and specific actions if an abnormal observation is identified. It is for whom? As already mentioned earlier, it is for women and their babies during labor and birth, regardless of their risk status. It can be used for high-risk patients as well as low-risk patients. However, the labor care guide was primarily designed to be used for the care of apparently healthy pregnant women and their babies. That means women with low-risk pregnancies. However, this can also be used in high-risk pregnancies, but one has to be careful. High-risk women may require additional and specialized monitoring and care. For example, in low-risk patients, you may just do intermittent auscultation, whereas in high-risk patient, you may use continuous electronic fetal monitoring. So that is an example. I have already talked about this. It is in a nutshell here. It is basically giving emotional support from a companion of choice, effective communication by staff, pain relief strategies, regular labor monitoring and documentation, oral fluids and food intake, modification of the labor birth with positive position of choice, pre-established referral plan and continuity of care, finally achieving respectful labor and childbirth care. So that is the main goal of this labor care guide. Now comes the details of labor care guide. When to initiate labor care guide? Because we all know when a woman goes into labor, initially she may be in a latent phase of labor, and this latent phase is indefinite phase. In some it will be 8 hours, some it will be 12 hours, some it will be 24 hours, and sometimes it is more. So do we monitor all these phases? When do we start? This is a very, very important question. When woman enters active phase of first stage of labor, regardless of her parity and membrane status. So there is no point in documenting this before active phase of labor. That does not mean don't bother, don't care when she's in latent labor. We have to bother, we have to care, but we may not monitor closely and we may not document closely unless she enters active phase of labor. That is first stage of labor. And this is regardless of parity, whether she's primigravida or multigravida, and regardless of membrane status, whether membranes are ruptured or not. Now, why I'm putting stress on this? Because this is the major difference here. In the old partogram, the active phase of labor was considered when she was 4 centimeters. But the new labor care guide says it is 5 centimeters or more. This is the major change in labor care guide compared to earlier Philpott's modified partogram. So we have to learn to remember this halfway through. She should be halfway through, considering 10 centimeters as the full dilatation. If she is more than 5 centimeters, she is in active labor. So probably I give an analogy of in the car, there are 5 gears: first gear, second gear, third gear, fourth gear, and fifth gear. Now, when you are in the fifth gear, that means you are actually very active in the transmission. And then in the fifth gear, it's the best efficiency of the car. So I will put it as fifth gear. Old partogram had 4 centimeter. So we have to remember 5 centimeters. This is the most important thing. Then what is this latent phase? The new definition for latent phase is that it is the period of time characterized by painful uterine contractions, all right, but there is variable changes in the cervix, including some degree of effacement. And the most important word which I put in red is slower progression of dilatation up to 5 centimeters for first and subsequent labors. That means whether it is primary or multigravida. In other words, latent phase is a period which is variable from woman to woman. In some women, as I earlier said, 8 hours. In 8 hours, she may come up to 5 centimeters. In some women, 12 hours. Some women, 24 hours. So there is no standardization. That means unless you hit the fifth gear, when do you hit the fifth gear? You hit the fifth gear in the car when the car is attained a steady acceleration and you hit a smooth road or a highway. Till that time, you may keep changing the gears from 1 to 2, 2 to 3, 3 to 2, 2 to 4. You may keep changing them. When you hit the beautiful road, highway, and you attain a steady acceleration, you feel like putting it on fifth gear. So that is the analogy that I always give. So new definitions of active phase, which I have already told, it is a period of time characterized by regular painful uterine contractions. In the previous slide, you didn't find the word regular. Here you found regular. Number 2, a substantial degree of cervical effacement and dilatation. And more rapid. What did we see in the previous slide? Slower. I put it in the red. Here I am putting it in the green. More rapid cervical dilatation from 5 centimeters until full dilatation for first and subsequent labors. That means primary or multigravida. So I hope we know the difference between latent phase and active phase. In latent phase, there is painful uterine contraction, but they are not regular. Here it is regular. And there is variable cervical effacement and dilatation, but here is substantial degree of cervical effacement and rapid dilatation. There it is lower dilatation. So I hope it's very clear. Now comes the big controversy. What should be the duration of first stage, second stage, and third stage? Now, women should be informed that a standard duration of the latent first stage has not been established and can vary widely from one woman to another. This is what I have been telling probably third time now. However, the duration of active first stage, that is after 5 centimeters until full cervical dilatation, usually does not extend beyond 12 hours in first labors and 10 hours in subsequent labors. Now, we need to little bit pause here and understand. When we were undergraduates, postgraduates, and when I was until professor, that means until 2020, I myself was teaching that the entire duration of first stage is 12 hours maximum in primary gravidas and around 10 hours in multigravidas. But here you have to clearly observe that 12 hour is given after 5 centimeters. They have been generous, which clearly shows that the first 5 centimeters is variable. You don't have to be worried much about that. But once she hits the 5th gear, that is 5 centimeters, you give her maximum 12 hours to deliver if she is primigravida and maximum 10 hours if she is multigravida. Whereas in the previous slides you saw no difference between primigravida and multigravida because it is variable. But once they hit 5 centimeters or the 5th gear, they define it clearly, 12 hours for primi, 10 hours for multi. Now, again, you should not be confused here. 12 hours does not mean they must mandatorily spend 12 hours. It is a maximum limit. And 12 hours does not again mean you go to sleep and come and check her after 12 hours. You have to be closely monitoring her, and I will tell you how to monitor that little later. Because if you don't understand this point, you will say the new labor care guide is very erratic, it cannot be followed, and there are other unnecessary comments will come. 12 hours is the maximum limit, not the mandatory limit. 10 hours is the maximum limit, not the mandatory limit. Now, progress of first stage with spontaneous onset of labor, the cervical dilatation at the rate of 1 centimeter per hour during active first stage, depicted as in alert line in the old photograph, is unrealistic and it is too fast for some women. If you recall the old partogram, we said after 4 centimeters, the cervix will go strictly 1 centimeter per hour. Over a large amount of study, these are all evidence-based, they realized it never happens. It is unrealistic and it is too fast. That means within 6 hours, she must hit 10 centimeters. But just now in the previous slide you saw, after 5 centimeters, they are willing to give 12 hours. Whereas in the previous partogram, Philpott's partogram, you have seen the alert line and action line. The alert line is based on the presumption or assumption that the cervix dilate 1 centimeter per hour, which means after 4 centimeter, to become 10 centimeters, she should take only 6 hours, which is totally unrealistic and totally fast. And it is inaccurate to identify women at risk of adverse birth outcomes. Just because she lacks a little bit, you jump and do a cesarean section. It's wrong. That's what is the meaning of it. Hence, it is not recommended for this purpose. So we discard this 1 centimeter per hour business. It is not good. It is not identifying labor problems also. Labor may not naturally accelerate until a 5 centimeter dilatation. It's the same thing again and again they're telling. Therefore, interventions to accelerate labor and birth, such as oxytocin augmentation, cesarean section, before this threshold is not recommended, which essentially means just leave her alone. Up to 5 centimeters, there is no need to do ARM. There is no need to augment labor with using oxytocin. Of course, oxytocin nowadays we don't start unless we do an ARM. And don't simply come under pressure from the patient and patient party and do a cesarean section. It is very easy for me to give a lecture like this here theoretically, but I know many a times nowadays, especially many women are restless. They can't even tolerate 2 to 3 hours of labor pain. Even the latent phase, they will say do a cesarean section. And we also are in a dilemma whether to do it or not to do it and things like that, and we land up in doing. Whole problem is neither the patient is having patience, nor the obstetrician is having patience, and we are all scared that should something go wrong, then the patient will blame us. I told you to do cesarean section, you delayed, you waited. For what you waited? You waited according to the labor care guide, you waited according to Dr. Muralidhar Pai's lecture, and you get into trouble. But these have to be understood clearly. and we have to explain to the patient clearly, provided that fetal and maternal conditions are reassuring. So this sentence should not be forgotten. Whatever it is, you should always believe fetal heart rate and maternal condition. All other things, emotional things, we should not come under. The cervical dilatation rates lower than 1 centimeter after 5 centimeter alone should not be routine indication. This is again and again telling the same thing, that don't always go by that 1 centimeter per hour business. There will be little bit of slowing down of the car. Depending, suppose even if it is a highway, even if you are on the 5th gear, suddenly you see one dog coming. Don't you little bit slow the car? Don't you little bit slow sometimes? Similarly, cervix also may slow down little bit, but again it may pick up. Don't go strictly by 1 centimeter per hour business. Now I told you, labor care guide also talks about second stage. How do we give that time for the second stage? In the old partogram, we always thought maximum 2 hours. In fact, it was not there, but traditionally we thought for primigravida maximum 2 hours and multigravida maximum 1 hour. But here it looks they should deliver within 3 hours. Now again here, don't say she's fully dilated, I will go and have my lunch and come, because 3 hours I can wait. It is not at all like that. Second stage is more and more important. You have to be very close to her. What it means is that, suppose there is no full rotation of the head. Earlier, we used to say maximum I would wait for 1 hour 45 minutes. After that, I would do some intervention, maybe vacuum, maybe forceps, or maybe cesarean section. What it tells is that if the fetal heart rate is all right, if the mother is all right, up to 3 hours you can wait. That is the meaning of it. In multis, up to 2 hours you can wait. So instead of 2 hours and 1 hour, it has become 3 hours and 2 hours. That is the difference. Now, when not to initiate, this is also very important. It is important to know what to do. It is also important to know what not to do. LCG should not be initiated during latent phase, telling the same thing in a different way. However, it is expected that women and their babies are monitored and that they receive labor care and support during the latent phase. This is the art of, the WHO and some Western literature writing. They tell the same thing again and again in a different ways. Once initiated, LCG should support continuous monitoring throughout the first and second stage. Of course, we know that. So WHO partogram, earlier one, didn't have second stage. Where should it be used? All levels, I told you already that. And for early identification, and it should contribute for timely referral. Now I come to the actual WHO LCG. This looks from a distance like an old partogram. If you just have a glance, what is glaring here is the action line and alert line are missing, because they have stopped believing that cervix dilates at the rate of 1 centimeter per hour. So you don't find alert line, you don't find action line. Instead of that, for every centimeter after 5 centimeters, they have given a threshold. How long you can wait in 5 centimeters, how long you can wait in 6 centimeters, how long you can wait in 7 centimeters, how long you can wait in 8 centimeters, like that. So it has got 7 sections, mota moti, that's the language used in Sikkim, more or less. It is same 7 sections that you get. What are the 7 sections? First one is identification information. That is not great. Number 2, what is the supportive care you are given? This is an addition in the new LCG. That means whether there is an accompanying person, husband, mother, mother-in-law, sister, neighbor, anybody, and whether you are giving her water or not. This was not there in the old partogram. Care of the baby was always there. Care of the woman was always there. Labor progress was always there in the form of alert line, action line. Instead of that, every hour, every centimeter. Medication was always there, whether you gave her oxytocin or not, whether you gave any other fluids, other injections or not. And the seventh one is again a new addition. What is the shared decision that you have taken? So I will go through each of that in detail. First, let us have a gross outline. Section 1 will tell us about the identification, name of the patient, when did the labor onset, when did the membranes rupture, same thing. Section 2, supportive care. Section 3, baby. Section 4, woman. Section 5, labor progress. And section 6 is medication. Section 7 is shared decision. Now let us go one by one. This is the main part of labor care guide. All this while it was Harikatha, but now is the actual how to document. Section 1, and of course I don't have to tell you, you start documenting when she is 5 centimeters. Of course, identification you can start entering anytime she comes to your labor room. Name and then parity, labor onset, when it was started. When was the active labor diagnosis? That is when she was 5 centimeters. And when the membranes ruptured, and if there is any risk factor, whether she's a case of preeclampsia, whether she's a case of diabetes, whether she's a case of whatever. So this is not a big thing. So as I said, but you start seriously monitoring after 5 centimeters. Before that, of course, you have to seriously monitor only, but you may not document. So it is like this, for example. Next one, 2 to 7 section, there comes the threshold, reference thresholds. It contains a list of labor observations. It should be recorded for all sections soon after the woman is admitted and after 5 centimeters. The remainder of LCG is then completed following subsequent assessments throughout the labor. So what is this monitoring to action? To ensure that systemic and consistent application of labor care guide, health providers are encouraged to use the following approach. Now, one is access, assess, record, check, and plan. So this is the progress. Assess, record, check again, and plan. This is very, very important. I want you to give attention. So this will continue, these columns will continue throughout section 2 to section 6 at least. And as you can see here, in the first stage, they have given 12 hours. This starts after 5 centimeters. Second stage, they have given 3 hours. For all observations, there is a horizontal time axis, as you can see, for documentation of corresponding time of observation, right? The blue box I made. Vertical lines is alert reference axis for determination of any deviation from the normal observations. So this is the alert that they are giving. It will be there in every box, don't worry. Then for second stage, maximum is 3 hours. It's in the green box. Now, how to enter the time? Above, you enter the actual time. She came to labor room at 6:30 in the morning. That is the 0 hour. From there, after 1 hour, it becomes 7:30, 8:30, 9:30, like that. Suppose she has achieved full dilatation by 12:30. In this particular case, she has hardly taken 1, 2, 3, 4, 5, 6, and 7 hours, which is well within normal. In the earlier one, we expected her to be full dilated in 5 hours because 1 centimeter per hour. But here she took 7 hours, which is fine. And then here by 12:45, she delivered the placenta. Third stage is over in 15 minutes, which is fine. So time is the actual time. Hour is the number of hours she has taken. This is very simple again. Now I go to the second section, supportive care. What are the parameters? Number 1, whether there was a companion or not. You will write Y if there was, N if there was no companion. D means woman didn't want anybody. I don't want husband, especially let's say she says in my labor room, or mother-in-law or anybody. I don't want anybody. Just the doctor and nurses are enough. So that is D. Alert is if there is N, that means no companion, it is an alert. Pain relief, second component of the supportive care. Whether you gave pain relief or not. If you gave, Y. If you didn't give, N. Woman declines, D. Alert is if you didn't give at all. That's alert. According to me, even D also should be alerted. If she declines supportive care or pain relief, we can make it as an alert. Should be careful. The third one is oral fluid. If given, Y. If not given, N. If woman declines, D. No prize for guessing. What should be the alert here? N. And finally, posture. If she is lying down supine or if she is mobile. Alert is if she is supine. I always used to tell my PGs, and I tell them, make sure that they are not lying on the back. It will compress the aorta and vena cava, and that is not good. She should be either mobile if she has no complications, or if she should be lying on the left side. Now you look at this same picture. I've just blown it up. So what are the 4 parameters? Companion. What is the alert? N, if there is no companion. N, if there is no pain relief given. N, if she didn't take fluids. And SP, if she is on the supine position. So how do you write that? Look at the same partograph. So at 6 o'clock, let's say she came at 6 o'clock. In the first hour, there was no companion. So you have written N and circle it with red. Pain relief, she did not take, circle it with red. And oral fluids given, so Y. Posture, she was mobile. But at 7 o'clock, she had a companion, so Y. She took some drugs for pain relief, so Y. Oral fluids was given, and she went back to supine position, so you circle it red. This is how, at a glance, you can make out what is happening. So you can correct. This is first hour, this is second hour. Now I talk about the section 3 about the baby. About fetal heart rate, N means no deceleration, E means early deceleration, L means late deceleration, V means variable deceleration. Which is the alert here? Obviously late deceleration. As far as amniotic fluid is concerned, I means intact, C means membranes ruptured, M means meconium, B is blood. Obviously, meconium is an alert. Blood stained is also an alert. So how do you enter that? I will come to that after this slide. Fetal position, A, occiput anterior, P, posterior, T is transverse. Which is the alert? Posterior and transverse are not good. So caput, 3+ is alert. As far as molding, obviously 3+ is an alert. So this is how it is depicted. It is given already printed in the form. So how do you write that? Look here. So you are writing at, let's say, 6 o'clock, the fetal decelerations was not there. Amniotic fluid was clear. C means clear. Position was posterior. Caput 0, molding 0. You already have a reference point here. That is the beauty of this labor care guide. When to get alerted, it is always written there. Right. So now the next point is the care of the woman. Urine, you will start getting alerted if the proteinuria is 2+. As far as acetone, you get alerted once the acetone is 2+. And as far as the pulse, we all know when to get alerted. If it is more than 120 or less than 60, systolic BP less than 80 or more than 140, diastolic more than 90, temperature less than 35 or more than 37.5, urine 2+ for protein and 2+ for acetone. How do you write that? This, of course, you check once in 4 hours. So 6 o'clock, it was 88, 120, 80, 36.5, and urine was negative. After 4 hours, not much of change. So nothing to be worried about here. Then you go for a complete picture so far. So all the things I have put here: supportive care, baby care, woman care. So you can see red circles, and when you see red circles, you should get alerted and you should take action appropriately. And as you can see here, we are not just leaving her alone. for 12 hours. We are monitoring her carefully hour by hour. Right. I'll go to the labor progress. This is the most important part of the labor care guide. This is where everybody gets confused because as you can see here, 5 centimeters, they are giving generous 6 hours. That means even though you have hit 5th gear, you can go as low as 6 hours for 1 centimeter. But the moment you reach 6 centimeters, you are given 5 hours in that 6 centimeters. The moment you reach 7 centimeters, in next 3 hours, you must hit the 10 centimeters. When you hit the 8 centimeters, you are given only 2.5 hours. When you hit 9 centimeters, 2 hours. So it is like this in the incremental. So alert values are, as I said, there should be at least 2 to 3 contractions. If it is less than 2 or more than 5, both are bad. Okay. And if it is more than 5 or continuous, it suggests obstructed labor or hyperstimulation. What should be the duration of pain? It should be somewhere between 20 and 60. More than 60 is bad, less than 20 is inadequate. Again, short, inefficient is not good. This is what is very important. As I said earlier, 5 centimeters, you can give her a maximum of 6 hours, but in these 6 hours, if there is a fetal distress, you may take her a first section. If there is cervix hanging loosely, that means you suspect CPD. When she hits 6 centimeters, you give her 5 hours. Again, 7 centimeters, 3 hours, 8 centimeters, 2.5 hours, and 9 centimeters, another 2 hours, she should reach the full dilatation. And second stage, of course, you give her a maximum of 3 hours. This is where there was a controversy. How can I give 6 hours for her? How can I give her 5 hours for her in 6 centimeters? Because old partogram rubbed off so much in our brains that she should deliver within another 5 hours once she hits the 5 centimeters. This is the major difference in labor care guide. Okay. Now, as far as descent, there are no reference values. It was not there in the previous partogram also. So I don't want to go for this elaborate. It is very clear to us. Wherever there is a problem, you put an X mark there. And if there is no problems, you write no. And in second stage, you write P to indicate pushing begins. This is how it is. Look at carefully. Here, 5 centimeter, of course, you start at partogram after 5 centimeters only. 6 o'clock, she was 5 centimeters. Now at 10 o'clock, that is 4 hours later, she is 8 centimeters. Is this okay? It's definitely okay. And in another 6 hours, like from 6 o'clock to around 1 o'clock, she was 10 centimeters. This is perfectly fine. No problem. Descent also occurred. So there is no problem at all. Everywhere it is green. But instead of being 8 centimeters at 10 o'clock, she remains 5 centimeters at 12 o'clock. How many hours elapsed? 1, 2, 3, 4, 5, 6, and 7. Even 7 hours later, she is 5 centimeters. There is something seriously wrong. You need not wait 7 hours. I'm repeatedly telling this. You can intervene somewhere here. You can intervene somewhere here. You can intervene here. You can intervene here. It depends upon reassessment. What is the reassessment? Look for the contractions. Look for the descent of the head. Look for cervical dilatation and effacement. And Dr. Pratap used to always say, application of the cervix to the head. Cervix should be well applied to the head. Then only you know that there is no CPD. And there should not be caput. There should not be any fetal distress. Then only you can wait for 6 hours. 7 hours is not at all good. That's why it is a red circle. So this is okay. Green, green. I hope I've clarified this point very nicely. And there's no medication is very simple. I can run through this. Whatever medication you have given, you write that. And as far as the other things, there is not a big shared decision is what is the assessment done, what is the plan, and you have to put a signature. This is also very simple. So finally, the plan could be, you can say you continue monitoring, or you ask for some diagnostic tests. You can augment labor by ARM and oxytocin, or you can do a forceps or LSCS. Anything is okay, but you have to document it. So take into consideration woman while discussing with her, take decisions. So here some of the examples given, what you can write. So I'll summarize now last 3-4 slides. In first stage, what is recommended is auscultation every 15 minutes or continuous electronic fetal monitoring, whichever is okay for you. Per vaginal examination every 4 hours. There is no change. Epidural analgesia can be given. Parenteral opioids can be given. Relaxation and manual techniques, welcome. Maternal mobility should be encouraged unless she is a case of preterm labor, preeclampsia, and any other problem or multiple pregnancy. Oral fluids, always welcome. What is not recommended on admission is that routine pelvimetry. Of course, it is question mark as far as I'm concerned. I always prefer to do a pelvimetry or CPD assessment, and that time only we can take a decision. If there is a gross CPD, take a first section. Why should she have worst of both worlds? Go through labor as well as then emergency section. Anyway, this is what is recommended, but I have put a question mark. This question mark is from my side. Routine admission CTG, not necessary according to labor care guide, but I have again put a question mark. This is always good to have a better baseline assessment. Perineal and pubic shaving is not recommended. Of course, it can have its own plus and minus. I don't want to harp on that. Enema is always welcome if the rectum is loaded, but in certain situations you avoid, for example, multiple pregnancy, preterm labor, you may avoid giving enema. Routine vaginal cleansing, again, they say it is not required, but it depends upon how hygienic the person is. Interventions less than 1 centimeter per hour dilatation is not required. This I totally agree. Further, continuous CTG definitely required for high-risk patient. According to labor care guide, not required. IV fluids to shorten the labor, not required, but you can put a IV line. Whenever it is required, it can be utilized. Active management of labor, you can do it actually, like ARM and oxytocin, depending upon the situation. Oxytocin for epidural analgesia is not routinely required, but if you feel that she is not progressing well, you can give it. Antispasmodic agents like epidocin, definitely no. As far as second stage is concerned, auscultation every 5 minutes, we all know that. Birth position, woman's choice. I heard that one of the VIPs wanted to stand and deliver, and she delivered, but you have to be very careful like Kirmani to catch the baby. Don't drop the baby. Pushing, you can always encourage, but encourage when she has got own urge. And preventing perineal tear, definitely welcome. What is not welcome is routine episiotomy. However, don't be hard on this rule. If you feel that episiotomy is better than perineal tear, please go ahead. Fundal pressure, definitely I don't encourage in normal labor. In cesarean section, when the patient is not pushing, we usually ask anesthetist to give us gentle push. That's okay. There we can manage the situation. Even if there is some small inversion, uterus is open, we can manage that. But in normal labor, not. In third stage, uterotonics, definitely welcome. 10 units of oxytocin and carbetocin, ergometrin or methyl ergometrin, whatever suitable. I don't want to explain that. Delayed clamping is the norm of the day. Control contraction goes without saying. What is not recommended is routine massage is not required. But if you suspect PPH, you have to massage. So thank you very much. I took a little bit elaborate like a real teacher. So sorry, but this is a new topic, so I had to go like that.
Thank you, sir, for that mesmerizing talk on labor care guide. We never fail to be inspired from you. Purushottam, sir, is he there, madam? Uma Shankar, sir.
Thanks, sir.
Aruna, madam, your comments, please.
Yes. Sir, thank you so much for such a good insight. It was crystal clear, sir. Everyone understands this, including MBBS, PG, the basic first year PGs also can understand the labor care guide. Till now we read, but it was not this clear. But what are the drawbacks of this, sir? What are the disadvantages of
Yeah.
following the labor care? Can you please give us some points?
Disadvantage is that it gives lot of grace period, and a little bit complacent doctor can misread this labor care guide and he may get into trouble. See, what is told is that the main philosophy, I would say, is that women vary in their speed. That's the basic philosophy. Don't expect all women to deliver in 10 hours, 12 hours, and things like that. But that should not make doctors complacent, careless, saying that labor care guide gives me 24 hours time to deliver, so I'll wait. So this is not expected. What is they never said that don't monitor, but they were extra careful probably to avoid unnecessary interventions and cesarean sections. I particularly feel this labor care guide is driven by that particular thought that people should not jump into drastic decisions. But I would like to highlight and underline, don't be complacent, don't take it easy, don't say labor care has given me 7 hours time to relax in 5 centimeters. I'll come back after 7 hours and see her. That is not acceptable. It never says that, you have to wait 6 hours. It says that you can wait up to 6 hours. There's a difference between have to and up to. So this has to be clarified. Otherwise, there's a tendency for people to just relax and get into trouble and blame labor care guide and blame this and that. So their thinking is that, please understand, all women, all jackets, there is no one size. There are different sizes. So we are all coming in different sizes and shapes. All of us have got 2 eyes and 1 nose and 2 ears, but we all look different. So every woman is different. Every labor is different. That is the philosophy.
Okay, sir. So there should be an individualization,
Yes,
separate
yes.
treatment for everyone, right, sir?
And
Thank you so much.
Bottom line is monitor closely.
Still in Telangana, we follow the partogram. Thank you, sir.
No, that is also okay. That has served us for a long years. In fact, that talk of mine was very famous. I removed it from YouTube. That had the maximum.
I know. Even I saw it so many times.
Yeah, 5,000 viewers were there, but I removed it because this has come. That should not confuse the people.
Yes, sir. Yes. So thank you so much.
Thank you very much, sir. And thank you, Aruna Madam, for chairing that session. Can we go over to the next session? I hand over to Dr. Niharika.
Thank you,
Dr. Sneha, for this opportunity. Please let me take 1 minute.
Thank you.
Thank
All
you.
of you. It's my
Sneha,
pleasure.
Dr. Sneha, once again, all the best to you. This year, you have to win and you will win.
Thank you so much, sir. Special thanks to you for making us understand all this, in depth. I'm sure all of us agree with me that, you really have learned this subject so well.
Yes.
Thank you so much. Thank you, sir.
Thank you, Dr. Muralidhar Pai sir and Dr. Aruna Madam for such a wonderful deliberation on the WHO Labor Care Guide. Now we have seen how to monitor women during labor. So let us make sure they get into labor by having a successful induction. So we have none other than our past Vice President Foxy, Dr. S. Sampath Kumari, to speak on this topic. And let me introduce the chairpersons for this session. Dr. A. Swarupa Rani. She is the founder of Mancherial Society and the present president of Mancherial Society and an active Foxian. Next slide, please. Dr. B. Venkateshwar Rao, sir. He is the professor and head of the department, Guntur Medical College, Andhra Pradesh. And he was the president of AP Obstetrics and Gynecology Society in 2019 and was the organizing chair for the state conference APCOG in 2019 and is the present president, Guntur OBGY Society. Welcome, sir. Next.
Is it
Dr.
there?
No, ma'am. I think both of them have not yet joined. Dr. B. Sandhya Rani is here with us. She's working at Lakshmi Narsimha Hospital, Warangal, and she's the head of the department for DNB Institute at that hospital. And she is also a director at Ikshila Hospital, and she's the past General Secretary of Warangal Society and an active member in many, many organizations. Welcome, madam. And I hand over the session to the chairpersons to introduce the speaker. Dr. Sandhya Rani.
Yeah, good evening, madam. It's a great honor to me to introduce Dr. S. Sampath Kumari, madam. She's a Foxy Vice President 2022. She's the founder secretary of TNFOG.
Yeah, madam, thank you.
Yes, national correspondent editor of Jogi. Madam is now ICOG governing council member from 2015 to 20 and president board status OG TN Dr. MGR Medical University. Madam, please go ahead your topic. Thank you.
Yes, Dr. Sandhya, thank you. I'll share my screen first. Is it visible? Yes.
Yes, madam. Now able to see.
Thank you for the nice words, Dr. Sandhya. I
Yes.
thank Dr. Sneha, AMOGS and Telangana Society for giving me this opportunity. First of all, I should wish Sneha for to become an VP this year definitely, and Aruna should become a committee chair, and Negarika in future. Okay.
Yes, thank you
My
so much.
topic is induction of labor. Thanks to Rajendra
Sampath ma'am,
Sir
your
and
voice
Kiran
is very
Kutty
low, ma'am.
and Shantakumari madam for being the chief guest and the past and the present president of AMOGS. The induction from now I had a
Madam, your voice is low, madam. Unable to hear.
voice is slow.
Yes.
Yes, ma'am.
It's normal only.
You will
Now
have to
can you
increase
hear?
the volume, ma'am. Oh,
One
ma'am,
minute,
it is low only.
The
You can go
device
to the
volume.
audio settings, ma'am.
Now can you hear?
No,
Much
ma'am.
better.
Has gone.
Device volume.
You can go to the audio settings, ma'am, when you have that mute
Now can
button.
you hear?
Ma'am, we can hear, but it is little low.
Now,
No.
hello?
Yes, ma'am. I think you can go ahead. If you can change it, it will be nice, but it's okay. You can go ahead.
Or you please be close to the mic.
Yes, that is the reason I think. Anyway, so the induction of labor. Now you had a wonderful talk by Dr. Muralidhar Pai. As Aruna told in our setup also, we are still following the partogram. We should change to the WHO bundle which Pai sir was talking. So the induction of labor, what is it? It is an initiating uterine contractions through medical, surgical, or combined methods to facilitate vaginal delivery. And after the fetus reaches the viability, always we have to wait till if there is no comorbidities and if there is no complications, you can wait till the date of EDD. That is about the 40 weeks. So what is the goal of our induction? Successful vaginal delivery while ensuring maternal and fetal and the outcome. And
Madam, not audible. Not audible.
Not audible. 1 minute. I'll ask. It's happening. Audio I have increased. Hello, now can you hear?
Not audible.
Still not.
Yes, madam.
Madam,
Able to hear, madam.
We can hear, ma'am. Go ahead.
Can hear, no? Then okay.
Yes.
And this is the goal. That is to reduce the cesarean section and have a good maternal and fetal outcome. What are all the methods? Now, the patient comes on the date of EDD, but she is not having pain, and we want to wait for 1 week or whatever it is. How we are going to give the pain? One may be the medical methods, mechanical methods, surgical methods. And this is the guidelines which the FOXI is also having. We have RCOG guidelines, ACOG guidelines, but practically we have to follow our FOXI guidelines. This is before going for the medical, mechanical, and the surgical methods. The membrane sweeping, always we used to do. Now, whenever we get an opportunity to assess the pelvis, previously we used to tell that at the end of 37 weeks, we have to do the PV to assess the pelvis. Nowadays, when the patient comes, even at the 40 weeks, you can go the per vaginal examinations and do a stripping that is called as the membrane sweeping, that is, it will improve the patient to enter the spontaneous labor, and it is suitable for the non-urgent indications. We can wait if there is no complications, no GDM, no hypertension, nothing means we can wait means on the data PDD you can do. And it can be done simultaneously, as I told, at the assessment of the pelvis, and it can be repeated also. If it is not spontaneous, after 3 days, again you can repeat this membrane sweeping. So now coming to the medical methods. Medical methods, all of us know we have the gel, police, and whatever it is. The medical methods, first we'll deal with the PGE2. PGE2 is the prostaglandin PGE2, dinopraston. This is available in 2 forms, as all of us know. One is the gel form and another is the pessary form, that is the surveyed. So what will happen with this, with the PGE2? There is only one side effect. That can be uterine tachysystole and high chorioamnitis in the incidence of the ruptured membranes. If the membranes are not ruptured, means you can go. Many of the places they are going with the prostaglandin gel only. What is that? There is always we should teach our postgraduate. To keep it in the temperature maintenance is very, very important. That is the reason nowadays the oxytocin, if the temperature maintenance is not followed, then may not be the effect. Then there may be the failed induction. So the gel has to be maintained in the refrigerator of 2 to 8 degrees Celsius. And what is the amount is 3 gram gels. It contains the 0.5 gram dinopraston. And always I used to tell, it should be in the cervical between the internal os and the external os. And if it is below the external os, when you go switch off for the episiotomy, there may be a continuous bleeding and oozing if it is elevated. And if it has crossed the internal os and gone into the cavity, means again uterine hyperstimulation, and immediately you may take for the cesarean section. So priming the cervix, that is between the internal and external os, application is very, very important, and it has to be repeated after 6 hours, maximum of 3 doses in 24 hours. So don't decide between the one induction of the cervical gel. If the patient is comfortable and maternal CCG monitoring is comfortable, you can go for the second. And as far as concerned, in our places, we are going up to only second doses. But as per guidelines, you can go for 3 doses in 24 hours. And patient can be ambulated after 30 minutes. Routinely, temperature, pulse, respiratory rate, blood pressure, everything has to be monitored. Whatever we are doing, this temperature has to be monitored and effect has to be monitored before and after. If necessary, once the gel is after one gel, if the dilatation is 4 centimeters, then there is no necessity for the second gel. You can go with the oxytocin with doing the ARM. And if it is 2 centimeters, then you can go with the second dose after 6 hours and monitor the pervaginal examination for the third dose, whether it is necessary, or you go with the mechanical methods and oxytocin. So this is the subephrine gel which we are doing. Then it comes the pessary. Only with the most of the corporate hospitals now they are using. In the government hospital setup, it is not available, but it is also very good medical method for induction. It is also stored in the freezer, that is 10 to 25 degrees Celsius. This is 10 milligram. It is placed transversely in the posterior pharynx. What it happens, it releases the PGE2 at a constant rate, 0.3 milligram per hour over 24 hours dosing period. So this pessary in our hospital now we have started using, but in the government hospital centers it is not useful, but it is not available. It also has the same effects like subephrine gel. Now we can give the desiccations to PGs also, comparing the pessary and the gel. And again here the ambulation is after 30 minutes, monitored at frequent intervals, and it has to be removed. It will be like the thread and the end. That has to be removed after 24 hours or at the onset of active labor. If the patient is now, you had a good discussion, 5 centimeters is the active phase and how long it has to be monitored, that things all has to be kept in mind. If it is in the active labor, automatically we can remove it, or after 24 hours, you remove it and assess the score. And if need, after this also, you can go with the oxytocin or whatever method you can. The rupture of membrane. Suppose if the patient is having the rupture of membrane, means this method is not advisable. There are studies which tells that that efficacy and the safety of the propers in a Japan country, and again in our place in Ramchandra Medical College, they have mentioned a study which tells that compared to the gel, this propers is having a more effect. And again, the vaginal, this is compared with the misoprostol also. oxytocin. Then comes the first we tried about the PGE gel and the pessary. The oxytocin always we go with the low dose regimen for the induction, 1 to 2 MU per minute. And gradually you can increase depending on the contractions. And at the 30 minutes interval, it has to be increased whether the contraction is present or not. If it is not present, the oxytocin is the only method of inductions when we were doing the house agency. So it can be given in the infusion pump also, and the maintenance is very, very important. 2 to 8 degrees Celsius. That is the reason now carbitocin is taking over, because carbitocin is not to be maintained. It can be maintained in the room temperature itself. Oxytocin, what it produces a smooth muscle lining, contractions, and pushes the baby. And oxytocin is a very good drug, but it has to be monitored very, very carefully. Then the mechanical methods, balloon device. Now we have the Foley's catheter. The Foley's catheter induction is very safe and cheap, and it is easy to store. And it produces the less hyperstimulation compared to the Cerviprim gel and the pessary. Also, the application is very, very important. Once you insert the Foley's catheter and the balloon, and the traction is important. So a small degree of traction of the catheter by tapping, and it should be in the end of the external internal loss, and the patient should feel the pain. He will tell some pain is there, some pain is there. And once you give the degree of traction and attach to the thigh. So application of a Foley's catheter is very, very important. If the patient goes for the labor, automatically it will fall by itself. And normally, as per guidelines, it can be kept for 24 hours, but we keep the Foley's catheter for 12 hours and we remove it. After the Foley's catheter, again, it can go even for the PGE to gel and oxytocin, whatever it is. So Foley's catheter and prostadine gel is one comparative study which we are doing in our hospital. It is the older study only. But after the Foley's catheter also, you can go with the gel for priming the cervix once the mother and the baby condition is stable. So the Foley's catheter induction followed by the oxytocin infusion is recommended as an alternative method for the induction of labor. Then comes the surgical method. This is the amniotomy, which always we follow that. This is also simple and effective method. Once if the membrane is bulging or if it is postdated, then first we have to do this amniotomy. Sometimes most of the people, while doing the pervaginal examination itself with a little pressure, this amniotomy can be done. But what is the important point is it has to be done slowly. So if there is a polyhydramnios and if you are going for an amniotomy, there will be a sudden gush of fluid and the card will also come out. So you should be very, very careful, and the fingers should have a control over the fluid coming. Otherwise, it can also go for the placental abruption. So amniotomy in an unengaged presentation. Suppose for a multi, what will happen? There may be the head will be mobile. It will not be engaged. In that cases, after doing the ARM, it will get engaged and automatically it will deliver. But it should be unengaged presentation. You should be very careful and drain the liquor very slowly. The vaginal fungus should not be removed until the presenting part rests in the cervix. So till the head comes and settles in the cervix, you should keep your fingers. So monitoring the fetal heart is very, very important before procedure and after procedure. And after the ARM, in case of postdated and all, we want to see the color of the liquor, whether it is meconium side, whether it is thin or thick. Previously, we used to tell. Nowadays, the color of the meconium has no importance. After that, you can go with the oxytocin infusion immediately or 2 hours after. So this is the way with the hook, amnio hook, we are allowing. Most of the time, expert and experienced surgeons, they will do with the hand itself. But this amnio hook, this is very, very useful. You can remove this membrane. If it is a high rupture of membrane also, with the amnio hook can be used and the lower part, the membrane is removed, and then the amniotomy, that is the ARM itself will release the prostaglandin and the patient will go for the labor. These are all the older methods, hygroscopic dilator, laminary tent. Nowadays, we don't follow this. Mifepristone in the term and all we are not using. Only in the first trimester we are using. Nitric oxide donors, relaxin, hyaluron iodizer. These are all the methods which was used previously. But nowadays we are not following. Even the breast nipple stimulation are not used nowadays. These are all the methods which are not recommended. Then coming to the misoprostol. This is misoprostol is not yet approved by the what we say FDA. It is not at all approved, but all of us are using. But it is a very good drug for even in the term. In the first and second trimester, it is approved. For third trimester, it is not approved. But with the careful monitoring, there are a lot of studies which tells that the misoprostol can be used. See, this is a prospective vaginal study comparing the intracervical dinoprostol and the vaginal misoprostol. But the conclusion is with the misoprostol, patient is going for the contractions and the duration is also reduced and PPH is also reduced. But these are all the results. Again, a lot of studies which tell sublingual misoprostol versus oral misoprostol. When you compare this, sublingual is very useful, but they are telling. But we have many studies to prove that misoprostol 25 milligram can be used. But still, it is not FDA approved drug, so you should be very, very careful. So the induction of labor with oral misoprostol solution is associated with higher vaginal delivery and the incidence of what to tell, LSCS is also reducing. So when you go for the mechanical method, the police induction, in that case also with the police induction, you can go with the oral misoprostol every 4 hours, 25 like that. But practically we are doing, but it should be very, very careful in monitoring the continuous monitoring is important since it is not an FDA approved drug. So this is another study which tells that misoprostol and anaprostol for elective induction. Randomized study in 2004, that is the oldest study. But again here to compare the safety and efficacy of 25 microgram of intravaginal misoprostol. Even the misoprostol, there are studies which tells that it can be kept in the posterior fornix and monitored every hour. We compared with the dinoprostol and the effect is more with the intravaginal misoprostol. This is the IOSR study and international study, comparative study of low dose vaginal misoprostol. So you can go with the low dose and you can try, but again, I am telling it is not an FDA approved drug. In Tamil Nadu audit, if you tell that misoprostol, that's all. So most of the time, what our PGs are giving, but they will not add document, but that is not the procedure. But with the comparative study, I think in future, misoprostol will be coming to all hospitals and it can be used very frequently. What are all the prerequisites for induction of labor? Informed consent is important. Review of maternal history and profile. History is very, very important. Most of the time, our patients will not tell about the heart disease also. The history is very important. And indications, whether what is the indication, what is the contraindication, what is the gestational age, presentation, whether you have to see whether it is cephalic or the fetal weight. For 4 kg baby, you cannot go with the induction. So the presentation, gestation, age, fetal weight, everything is important. And the CTG, before going that, the baseline heart rate is very, very important. Pelvis assessment is important before induction. And the Bishop scores, whether it is acceptable, whether it is less than 6 or more than 6, whatever it is, the modified Bishop score system has to be monitored before going for an induction. Write the score, write the assessment, write the pelvis, membrane situation, consent, everything is important. As the maternal pulse, BP, the normal vitals has to be monitored. So we will go with the special situations, some situations. First, indication for induction of labor is mostly with the postnatal. Normally, what we are telling, the prolonged pregnancy, which is up to the 42 weeks. But there are ACOG guidelines which tells that we have to induce the postnatal from 41 to 42 weeks. But in our situation, every hospital should have their own protocol. Once the 40 weeks is completed, +1 or +2, whatever the protocol in your hospital, that has to be followed by all the units. So which is suitable for our place, it has to be done. Hypertensive disorders for women with preeclampsia, induction should be planned at 37 weeks. If they are having only labetalol tablet and it is a case of gestational hypertension, you can wait in the data PDD also, but monitoring is very, very important. Preeclampsia means if there is any signs of the end organ damage, sometimes in between she would have complained of headache, sometimes she would have complained of upper epigastric pain. That cases and all, we should be very careful and monitor after the 37 weeks. Once you consider the patient, if the BP is increased after 20 weeks, at any time gestational hypertension can go for preeclampsia can go for eclampsia. So once after 20 weeks, the BP is increased means always you should have in mind, ask the patient headache, blurring of vision, upper epigastric pain, reduced urinary output and movement of the fetus. That has to be monitored. These are all the guidelines. If there is no complications, you can wait till 37 weeks. If there is any history and any complications present, you can terminate at any time. Depending on that, one day induction has to be followed in case of hypertension. In the MMR, again in our places, hypertension, eclampsia and PPH is the common cause for MMR, increase the rate of MMR. So always careful you should be. At this post-dated, as I told, Up to 42 weeks is the postpartum pregnancy, but late term induction, these are all the guidelines, RCOG guidelines, which tells that you can wait till 42 weeks and the late term inductions up to 41 weeks. But in your hospital, what is the protocols? Once completed 40 weeks, 40 to 41 weeks, you can wait, monitor, but you have to ask the patient to monitor the fetal movements. With the knot, they can do it, and every day, alternate days, you have to assess the fluid level. You have to do the CPG that has to be monitored. In suspected macrosomia, 3.5 is macrosomia in our places. In that cases, you can go up to 39 weeks. So antenatal testing used in the monitoring of 41 to 42 weeks pregnancy should include at least a non-stress test and the amniotic fluid volume. This is the guidelines. But then with the oligohydramnios, always with the oligohydramnios, we will have the scan findings that Liker will be 9 centimeters and they will mention as oligohydramnios. So by if it is about 8 or less than 5, then again the induction of labor can be followed. With the amniotic fluid less than 8, again you can consider the patient. As per your hospital protocol, you can go with the dinoprasad gel or you can go with the police catheter also, but monitoring is very, very important. To prevent antepartum stillbirth, ACOG tells that the induction of labor at 36 to 37 in pregnancy complicated by the oligohydramnios, but monitor. But low amniotic fluid or otherwise, this is another guidelines, which Canada guidelines, which tells that low, that is if the Liker is 8 centimeter, it is like other cases only, but no special indication is labor. But if it is less than 5, always you have to take into account. So each obstetrical department should establish the guideline department for the local resources for scheduling the labor induction. So always you should have your own hospital methods. GDM, again, diabetes, induction of labor is not recommended before 39 weeks. If the patient is having a low dose of insulin and if they are on the mild diet and no complications and it is only GDM means you can wait up to the 39 weeks. If it is the pre-GDM and flexible insulin level, insulin dose and higher doses means you should be very careful in doing the induction. And uncontrolled diabetes, you go for the site LSES. Management of women with uncontrolled diabetes should be individualized. Always the guidelines for it's not for mathematics 1 + 1 is equal to 2. All cases, all complications, it has to be individualized. Next comes the IUGR. Again, the induction of labor at term is advisable for FTR babies to prevent the stillbirth. But again, here the monitoring, whether the Doppler monitoring is very, very important, where a reversal is present, absent is present, umbilical artery, cerebral artery. So depending on that, each case you have to be individualized. If everything is normal and Doppler is normal means you can go with the induction. Induction again as per protocol, gel or police or misoprostol. Still it is not FDA approved. Depending on your hospital, you can go. The multiple pregnancy in uncomplicated twin pregnancy where there are no contraindications to vaginal delivery, inductions can be done at 37 weeks. And the contraindications for induction of labor in twin pregnancy is the first one, which is non-cephalic. So otherwise, again, you can go with the inductions, but it should be very, very careful in case of the multiple pregnancies. The previous LSES, we have a lot of studies which tells that no medical methods, only the mechanical methods have to be used. But I don't know practically how many of you are going for induction in a case of previous LSES. To be frank, if the patient comes in the good labor of more than Morley that I was talking 4 to 5 centimeters only we go for VBAC. Induction we don't prefer, but mechanical methods of induction is advisable in case of previous LSES cases. So preterm PROM, again, if it comes in 34 weeks or 37 weeks, the patient comes with a history of leaking membrane. Again, the induction of cerviperin gel is PGE2 gel is advisable. In that cases, as per guidelines, we are going with the gel only. But if in these cases of preterm PROM, if we go with the oral misoprostol 25, it will be very, very effective because with the draining of the gel may also come out and then some as a failed induction. So depending on your hospital setup, you can go with the misoprostol also. These are all the guidelines which has to be done. So all this preterm labors, antenatal steroids and antibiotics. Once you do the PV means better to go with the antibiotics and the antenatal steroids to maintain till the steroid effect. If the preterm rupture is before the 32 weeks means again for neuroprotections of the baby, you can go with the magnesium sulfate. For the effect of the antenatal steroids and the magnesium sulfate, you can give the tocolysis. Maximum of 3 days to 4 days, it can prolong. Or once the steroid dose is over, you can go with the inductions and deliver the baby. So these are all the contraindications for induction: placenta, vasa previa, transverse slide, genital herpes, and CPD, previous uterine rupture, umbilical cord presentation, prior classical or inverted T structure incision. If it is in the discharge summary, it will be very, very useful. Invasive cervical cancer and previous pelvic surgery. These are all the contraindications where you cannot go with the induction. So monitoring is non-stress testing, recommended intermittent maternal and fetal monitoring, continuous electronic monitoring. It is very, very useful. Progress of labor using the parthogram, since we are using still the parthogram I have mentioned, but you can go with the bundle care bundle also. Now, as far as now, we are following only the parthogram. And all the vitals and the bleeding, vaginal bleeding, hyperstimulation has to be monitored. So the final counseling is indication for induction of labor has to be mentioned. And the risks and benefits of the induction has to be explained to the patient. And what is the method of inductions and what is the advantages and disadvantages has to be explained. Use of the electronic equipment for monitoring, that is the continuous monitoring. Expected duration of labor has to be told. Some patients may ask, you are doing for 2 days, what happened? What will happen to the baby? So you have to mention. And the support system. Suppose if you don't have a good setup of HDU, and if you don't have an ICU means, again, it has to be explained. It is better to have at least HDU. Pain relief depending and option available about the inductions. In case of IUD, again, depending on the pelvis, just like that, we cannot go. So, if it is more than 7 days IUD means you cannot go for an induction. You have to try other cases. You have to monitor with the disseminated DIC, and inductions methods are PGU2 or oxytocin can be used for IUD. PROM already I have discussed the same thing. So this is the induction occurrence, medical, cervix favorable, oxytocin, and PGE2, cervix unfavorable, prostaglandin preferably, surgical method membranes is bulging means ARM, and post-dated also ARM. You should be careful with this. And special advantage, both this medical and surgical can be combined. Cervix unfavorable, again PGE2 oxytocin, write the cervix and then go with ARM and syntocin. Favorable cervix, ARM and oxytocin. Thank you. Once again, I thank you, AMOGS and Telangana Society for this wonderful opportunity. Induction of labor is, hospitals should have their own protocol and monitoring is very, very important. Thank you.
Thank you, Dr. Sampath Kumari Madam, for a very excellent and elaborative lecture on induction of labor. Madam, one question, like the role of mifepristone. So mifepristone 200 mg for induction of labor. There are a lot of studies and literature available, and recently we have given to one of my PG for thesis protocol like 200 milligrams of mifepristone for induction of labor.
What term, madam?
Versus mechanical method of Foley's catheter.
No, madam, mifepristone we are not using in our place. If you go for ethical committee also, they will not accept. In our places, they are not accepting. I have never used mifepristone for induction. Let me know the results of your PG.
Yes, madam, definitely. Definitely, she started recently 3 months back. Role of mifepristone 200 milligrams versus the mechanical method of Foley's catheter. So the committee accepted, ethical committee accepted the her topic, and she started doing cases.
First and second we are using, not for term. We will see.
Yes. Thank you.
If I can just add, Madam Sampath Kumari, excellent talk. Whatever, right from the start to finish, you've covered everything. I just share with you that Dr. Nozar Shariar has been using routinely this mifepristone just when the patient is, approaching her due date, 1 week prior his time. 39 weeks is the ideal time, as now everybody's agreeing that maybe you can even go for a routine induction, though again there is a dilemma and the debate continues, but many people in Mumbai, they are using mifepristone for, induction of labor.
Thank you, madam.
Tamil Nadu, what happens, even the misoprostol, the Tamil Nadu government is not accepting. So in the government hospitals, they are not using the misoprostol. Only the other hospital like Vellore CMC, Zipma, and the corporate hospitals, we are using the misoprostol because something So it's, I don't know if mifepristone effect, when it will be used in Tamil Nadu, I don't know.
Okay, thank you so much.
Thank you, Sneha.
Uh,
The best, Sneha and Aruna.
I would like to congratulate the whole team for such a wonderful topic. It is the need of the C-section rate going up, and now induction of labor, monitoring labor, high risk, everything is very, very important for everyone, especially the juniors. I congratulate you all. And to see to that the normal delivery happens, I have seen in my practice that regularly we have been prescribing iron, calcium, and multivitamin for all antenatal mothers. But it is better to discontinue calcium after 34 weeks. That is my observation. Anybody has anything to contribute to this, please, it is welcome. I'm Dr. Swaruparani, President of Mancherial Gynec Society, Telangana. Yes, ma'am.
I don't think why you want to stop calcium, because the calcium itself you are giving for preventing the PIH, and if you have any positive points, you can tell, madam. I have no idea why you want to stop at 34.
No, does it
Are
cause
there
any
any
uterine
studies?
quiescence? No, ma'am. Like I have been watching it. Like after 34 weeks, if you stop calcium, they are setting into spontaneous labor. Does it have any role in uterine quiescence? That is my question. So anybody has any literature supporting that, please help me. No. Okay, let us see. Anyhow, it was a nice talk, madam. Thank you.
Yeah,
Thank you.
I think we can think of the calcium channel blocker, how they are being utilized, for prevention or treatment of the preterm labor. And definitely, if you think on the mechanism of labor, the onset of labor, it does have some relation. I don't think we have thought on this line to stop the calcium, and I think that's a good innovative idea. If at all we can work on it, and really if you have some experience, you may collect some data so that all of us can come up with some solid inference from that, and maybe we can utilize that.
Yes. Thank you. I thank all the chairpersons, Dr. Swarupa Rani, Dr. Sandhya Rani, and Dr. Venkateshwar Rao sir for their excellent inputs, and Dr. Sampath Kumari madam for a wonderful deliberation. And I think we got a lot of new insights today on induction of labor. So I hope we'll take it somewhere. So now I hand over this to Dr. Sailaja for the next session. Thank you.
Yeah. Thank you, Niharika Garu. We will be going over to our next session, that is the panel discussion on labor emergencies, being moderated by none other than Dr. Sneha Bhuyer, who doesn't need an introduction. All the best, madam, for your election. Our panelists are Dr. Deepika, presently working in CKM Hospital, Warangal, and assistant professor in KMC. Dr. Manasa Syamala, clinical head consultant at MedHealth Hospitals, Warangal. Next slide, please. Dr. Pratibha, presently running Pratibha Nursing Home. Next slide. Dr. Sriharsha Rauri, who is the Clinical Director, Birth Health Fertility Center, Guntur. Next slide. Dr. Anita, who is the Senior Lead Consultant OBG Clinical Safety Officer at Aster Ramesh Hospital, Guntur. And Dr. Lakshmi Chaitanya, who is a Consultant Obstetrician and Fertility Specialist at Chaitanya Hospital, Kadapa. Welcome to all of you, and I hand over the session to Dr. Sneha Bhuyer.
Thank you so much, and a very good evening and a warm welcome to all of you. And I utilize this opportunity for sharing knowledge and experience together. It's been said that you should never stop learning, because life never stops teaching you, and that's how we will try and learn together. We are here for the panel discussion on the labor emergencies. I will just take a moment. I think really sorry, I'll just that. I thought the presentation is open, but somehow I missed it. I'll just take a moment and open it. I hope you can see my presentation.
Yes, madam, we can see.
Yes. So I welcome all the panelists. Dr. Shailaja, thank you so much for introducing them to me. And I'll just start without much ado. Friends, you will all agree that childbirth is a sentinel event in the woman's life, and her family as well. You can see that it's not only emotional but intensely physical as well. So she has to go through lots and lots of emotional as well as physical, stress and strain during labor. So it's not very easy as you see 1, 2, 3 push and the baby's out and the mother and baby and the whole of the family is smiling. It's not so that all of us obstetrician we know this. The aim of labor is to have a healthy baby from a healthy mother, and it should be an emotionally fulfilling experience. I'm sure you will all agree to with me that for the obstetrician, may it be during their training course, may it be even after 30 years of practicing, the management of second stage of labor still remains a confusion or a confused thoughts. Action is taken depending on whether you are the protagonist or antagonist of the timely and appropriate intervention. As we have, initially it was the masterly inactivity and watchful expectancy, and then there was an era of active management of labor. The O'Driscolls followed, and again we have come back to this labor care guide by WHO, which is nearly, as good as masterly inactivity and watchful expectancy. So we start with this first case discussion. We have this 35-year-old grand multigravida who is delivered by Dai at home. The placenta is also removed at home. This patient is brought to the labor room or labor ward with profuse bleeding. Her vitals are, pulse rate is high, 120, blood pressure is low, and at this point of time, may I ask the first panelist, what is your diagnosis, the clinical picture?
Good evening, madam.
Yes, good evening.
Madam, it is a postpartum hemorrhage.
Yes. So from the clinical history, you get the diagnosis of postpartum hemorrhage. When further you are provided with this, this picture actually, and you have this clinical picture. When you examine her per abdomen, the uterus is not felt. Locally, she's full of blood. When you examine per speculum per vagina, there is a large fleshy mass in the vagina, and the cervix rim is not felt. Now, Dr. Deepika, what is your diagnosis?
Madam, it is acute inversion of uterus, madam, following delivery. It is acute inversion of uterus as the uterus is not filled and almost all the part of the uterus is outside the vagina along with the placenta.
So how will you go ahead with the management of this patient?
Madam, first I would like to correct the vitals, madam. As the pulse rate is high and there is hypotension for the patient, I would like to secure 2 large wide bore cannulas, madam.
Yes.
And send for
call for help first.
Yes, madam. Definitely, I'll call for help.
Yes.
And I would like to go for the baseline investigations like HB and blood grouping, and also I would like to send for cross matching, madam.
Correct.
And
call for help. You will call all your team.
Yes, madam.
Staff and the
I'll call all my
well.
team. Yes, madam. And first, I would like to reposit the uterus manually, madam.
Okay. How would you do that?
The first part, the part which comes last should be deposited first, madam.
Yes. That means which part closer to cervix?
Closer to cervix should be deposited first.
First, correct.
And the tip the fundus of the uterus, which is out, should be deposited last.
Last, correct, perfect. Then what will you do?
And with the other hand, one hand should be used with
Yes.
for deposition, ma'am. And with the other hand, we should be placing on the abdomen and hold the uterus.
Yes, to stabilize the uterus.
To stabilize.
Okay.
Yes, madam. Yes,
Yes.
madam.
So you have these various degrees. In spite of whatever the degree of uterine inversion, you have to go by this method. You have to wear the high-level disinfected gloves, and then of course you have to try and repose if it can be reposed at the earliest, because that itself may correct her shock also if it is a neurogenic shock, right?
Yes, madam. Yes,
okay.
madam.
Now, what else you will do? See, this
madam,
this is what you have described till
yes,
now.
Madam.
The first diagram you have to repose and then try and repose it completely. Then the fundus is also reposed, and you keep your fist inside for some time. And then what you do? You have to start with the uterotonics.
Uterotonics, madam. Yes.
You have to see that you have to keep that hand for some time inside only. You have to give the appropriate uterotonics, maybe preferably methergine here, and then the oxytocin infusion.
Oxytocin, carboprost.
Yes, madam. Yes. And how long do you continue the oxytocics? Anybody can take up this. Anybody can join the discussion. Okay. Can Dr. Harsha? Yes. Can we have can we take the discussion ahead, Dr. Anita? Yes.
Ma'am, as long as we feel the uterus is retracted, and even we can continue the oxytocin drip postpartum period also for the next 5 hours also in the drip, when we can give 100 ml per hour, we continue it so that the uterus remains in the contracted state and it doesn't we don't have the
24 hours, preferably 24 hours, but not less than 6 hours. Okay, suppose you could not repose this because this patient has come to you late. What are the other methods?
Madam, as I've called for help and kept everybody ready, I will even inform my anesthetist to give me some relaxation and help me repose it in the operation theater under relaxation, probably with tocolysis, a terbutaline or a nitroglycerin, whatever is available immediately at that point in time. And if I'm still not able to repose it, then we would go ahead for the next surgical procedures.
Yeah. So before that, there is one method what is called as hydrostatic correction. If any of the panelists are ready with this procedure, anybody can describe. Okay. So we have this procedure. So you have to, give a very deep Trendelenburg position to the patient. That is at least half a meter. Her head should be below the level of perineum. And then you prepare, the douche of at least 2 to 3 or 3 to 5 liters warm saline. And you put the nozzle of the tubing into the vagina with your right hand. And you, with your left hand, you close the labia minora so that you tighten the tube, and then you ask your assistant to send the fluid under pressure. So that is how, if you along with the pressure per se, that is hydrostatic pressure, the uterus which is inverted may get corrected. That used to happen previously, though we have not witnessed all this method. And once you have the correction, definitely again the same thing you have to follow, that you have to keep your hand, you have to keep the uterus contracted and well retracted at least for the first 24 hours. Okay, so if the manual reduction or the hydrostatic approach fails, then we come to the surgical the approach which is imperative. So Dr. Manasa, can you know what are the surgical methods available for this?
There are two kinds of surgeries available. One is the Huntington's operation and the other one is the Halton's operation. In the Huntington's operation, it is under general anesthesia.
Yes.
The peritoneal cavity is opened and we are exposing the inversion site where a crater will be evident in the region of the cervix. Then introduce 2 Alice forceps to the crater and use them on each side to provide gentle upward traction, pulling the uterus out of the constriction ring and restoring it to normal position.
Yeah, so what is this procedure?
It is called Huntington's operation. It's a laparotomy and the name is Huntington's operation.
Yes. And what is this one which we are showing you? Just open the abdomen, you pack your bowels, back, and then you put your one hand in front and put your other hand behind, and you try to squeeze the uterus upwards like this, and you see the fundal deep like this. Okay, so this is also one more procedure, surgical replacement or surgical correction of the uterine inversion. Okay, so this is actually, if this fails, then we go for Huntington's procedure, where whatever you have described, this with the help of Ellis forceps, you try to pull the round ligament, and you try to, advance your Ellis's further and pull the fundus up. Okay, what is Halton's procedure?
Similar to that, but a incision is made extending into the
posteriorly into the cervix. Right. So if the cervix could not be relaxed by stretching manually, then you have to cut. You have to make it widen so that you repush the uterus, try and fundus inside, and then you close it. Very simple. Okay. Anything else? This is again the Halton's procedure. Okay, what is shown here, how the incision is being closed. And you do have certain, very simple methods like, with the help of vacuum, you can just pull on, with the suction, the uterine fundus gets pulled up, or maybe like this with the balloon, you also can support it and pull it up. So these are the various methods, and the less common ones, the Spinalis, that is anterior colpotomy, and the Kussner's, that is a posterior colpotomy. And if everything fails, then you may have to go for hysterectomy if at all the blood supply gets hampered. So these are the worst of the possibilities. I think these are from the very old days, and this you don't get to see it nowadays. Okay. So post-operatively, as we have discussed already, that you have to keep this uterus well contracted and retracted at least for 24 hours, but not less than 8 to 12 hours. So you have to use whatever uterotonic required. Okay, may it be right up to the prostaglandin and injectable prostaglandins as well. Nowadays, you all are using oxytocin, carbetocin, whatever oxytocics you have been using, that should suffice. But in case of the atonic uterus, you definitely need to use the injectable prostaglandins. So I think we have done with the first case, and I'm sure though the uterine inversion is quite uncommon nowadays, I wouldn't say rare, though quite uncommon, it can happen, maybe especially in the periphery. And all of you, I would just ask Dr. Deepika to, say that what has led to this condition, what precautions do you advise for the obstetrician not to, land up into this complication?
Madam,
yes.
Uterine inversion is prevented by controlled contraction, madam. And the left hand and the placenta removal should be with the
but is that the only thing? I'm asking you, what are the conditions leading to this? I mean, what are the causes?
Atonicity of the
one, yes.
Atonicity is one, ma'am, and inadvertent pulling of cord before separation of placenta.
Mismanaged third stage of labor.
And if there is any the length of the cord is short also, we can expect this, ma'am. And if there is any adherent placenta also, if removed before separation,
we have to keep all these things into mind, and we have to definitely work on it to avoid all these complications. Okay. Thank you so much, Dr. Deepika. And now we go ahead with Dr. Pratibha now. This is the second
Good evening, madam.
Good evening. So we have this primary with 37 weeks. She comes to you in early labor. Her vitals are good. She's got only mild to moderate contractions, 25 seconds every 4 minutes. When you examine, you find that the fetal head is still floating, mild contractions. Fetal heart is very good, 140. And after some time, you find a sudden drop in fetal heart rate. What is the diagnosis you feel from this history? And how would you go ahead with the management?
Madam, first of all, I would try to see if it's a transient drop in heart rate or is it recurring. So for this too, I mean, I would substantiate with this by taking a CTG, baseline CTG. In the CTG, you would always know if it is.
But this I would stop you here, that maybe we are doing the admission test as a routine, or maybe we are doing the NST just near term, okay? But now you have this patient where there is sudden drop in fetal heart, that is substantial drop in fetal heart rate.
Okay.
So whether you would go for the NST and give time to that, or you will act, because this is a full-term pregnancy with sudden drop in the fetal heart rate.
I would also do
any contractions, without any strong contractions.
Okay, it could be a case of, I mean, cord prolapse also in a case of polyhydramnios on doing PV, which I would know.
Not necessarily polyhydramnios, because it's a floating head, no? See,
Yes,
she's a very normal routine primigravida, and she doesn't have any risk factor. Only her fetal head is floating, and she's in early labor, right?
Okay.
Yeah. So what is your diagnosis here? What else can you think of?
Or the patient is going towards cord prolapse is one thing, madam.
Yes,
but then before jumping into something so serious, I would just try to see if it is transient or is it recurring. So
but rather
that's
than going for the fetal heart rate, what I would suggest you as an obstetrician, that you have to see that there's no leaking. You have to see that there's no leaking, bleeding, and you have to confirm that there is no cord prolapse. Then you go ahead with that is what I wanted to tell you.
Yes.
That you have to think of the serious, serious reason first. You rule out the serious one, you relax, and then you act comfortably. Okay.
Okay.
This is what the message is. Because here there is a sudden drop in fetal heart without any reason. So we have to keep this in mind. Okay. Suppose now you have this case at your hospital, right?
Okay.
Then how will you manage her?
I would put her on head low position with legs with lower limbs elevated. Also, I would give her Foley's catheter. I would catheterize her with Foley's. Then I would immobilize her, and then I would immediately take her up for delivery, which would be, of course, cesarean section only, in order to salvage the baby. Because due to cord compression, the baby might get into trouble.
Okay, so this baby has got, it's a live baby. There is a fetal distress, and then you confirm that yes, suddenly she has ruptured her membrane spontaneously, and she's got cord prolapse. So there is nothing else which can be done rather than deliver the baby, but whatever means you can do, deliver at the earliest, right? Okay.
Yes, madam.
If this was a dead baby, then you could have thought of the vaginal delivery.
Yes, madam.
Right. But for a live baby, whatever modality you can deliver the baby at the earliest. Because if it's a full dilatation and you feel that you can deliver the baby at the earliest, then that would also be fine. Okay.
Yes.
What message we want to give here, that what are the reasons here which can land up into, which can make this condition, which can face this condition. What are the reasons for cord prolapse?
May I, madam?
Okay. Yes, Dr. Arsha.
So, since you have said this head is unengaged in this particular case, probably early ARM
floating head, yes.
Yeah, floating head. So ARM in cases of high presenting part would be a risk factor for the cord prolapse, and thereby subsequently the sudden drop in the fetal heart rate might occur.
Yes, but we have not done her ARM. It is written here that she is also not aware why there is sudden fetal heart drop, right?
So
it's a spontaneous rupture of membranes. Okay.
In such cases, we should think about the risk factors causing the cord prolapse, like in cases of low birth weight babies, in cases of the low-lying placenta, in cases of malpresentations like breech or transverse lie, or in certain cases like multifetal gestation where there is a second twin causing this cord prolapse. And also in cases of pre-labor rupture of membranes, and sometimes in cases where we are doing maneuvers like external cephalic version, there is a chance that the
membranes may rupture
and cord prolapse might happen. So these are the probable risk factors for the cord prolapse to be expected.
Right. So what precaution you should take? That is what the message is.
So whenever there is unengaged head, I think ARM should be avoided in such cases. And also when we are expecting, like we know the risk factors where the cord prolapse can be expected, like the conditions which we have mentioned now.
Yes,
in such cases, maybe if the patient is from far off place, we can admit her, when we're expecting labor. Like near to term and all. So, and also whenever we are doing PV examination during, that is before labor, and during labor, when we are doing pervaginal examination, probably undue pressure on the presenting part.
Take care that we don't rupture her membrane.
We don't, yeah. And after a rupture, suppose we have done ARM, it's always better to do a fetal monitoring as a mandatory thing after the rupture of membranes. Either spontaneous or it is like we have done the rupture. And these are the basic preventing factors or precautionary measures.
Yes, so these are the pre-labor, that is antepartum risk factors, where you have the various, even the transverse lie, oblique lie, and the various malpresentations, which makes it the absence of the ball valve mechanism. When you have, even with cephalic presentation, when the head is not engaged, not fixed, that is where the liquor can escape, and it can lead to the rupture of membrane, so that, or even the cord prolapse. So whenever you have such conditions, you have to see to it that near term you do the ultrasound, you confirm the presentation, and you advise them. Maybe if it is the breech presentation, you may try to go for the external cephalic version, or if it is a transverse lie, you hospitalize the patient and you ask them to go for elective cesarean section, right? In addition to this, you have to confirm that it's not only the frank cord prolapse, but sometimes you may have what is called as cord presentation. So may I ask you, Dr. Anita, what is the difference between the cord presentation and cord prolapse?
Madam, cord presentation is the descent of the umbilical cord beneath the cervix and with rupture of membranes. A cord presentation is something wherein cord presentation is something wherein the membranes are intact. We can feel during our pervaginal examination the fetal pulsations when it is just lies between the membranes and the presenting part.
Perfect. So now, what if you diagnose cord presentation antenatally, or maybe
antenatally? Yeah, I would first confirm the gestational age of the patient. When I'm doing a pervaginal examination, when I identify that it is a case of cord presentation, I will educate the patient and their attendants regarding the risk.
There. Even if you diagnose on ultrasound that it is a cord presentation, would you go ahead with the internal examination?
Ma'am, I will explain to them that this is a case because 100% we can't be sure sometimes, and we explain to them that the risk factors associated with this, and by doing a pervaginal examination, we can confirm
Suppose on ultrasound, there is a cephalic presentation, the membranes are intact, and very nicely you can see the umbilical cord, you can see the flow also, the documentation is perfect that there is a cord presentation. Would you go ahead with internal examination?
At that point of time, I will not go for an internal examination. I will counsel and educate the patient regarding the diagnosis and explain to them the risk factors. At any point of time, set into labor, it is always better to be in the hospital. That's the reason I would want to confirm the gestational age, the plan for the mode of delivery for the patient, and explain that, like if we do a pervaginal examination, what are the risks of rupture of membranes, emergency cesarean section. It can be a category 1 cesarean section at that point of time. So explain to all the liabilities that we need to face, and probably counsel them, and if the head is mobile, counsel them the need to go for an elective cesarean section if we have reach it term if it's 38 plus weeks.
Yes.
And then basing upon.
Yes, perfect. So, see what the RCUG guidelines also say, because all of you know that once it is a cord presentation, any moment, even if you don't rupture the membrane, she can spontaneously rupture the membrane. So if it is 37 weeks, why do you want to wait for that? And what are you going to achieve by doing internal examination? She's not going to deliver vaginally. So when you have the documentation of cord presentation, maybe around 37 weeks, you have to conceal the patient and the relatives and go for elective cesarean section. No point of time, internal examination or ARM is allowed here. So that is what we have to keep it in mind. So we have to identify the patient and risk. At the same time, we have to do the early detection of cord presentation, and definitely we have to go for elective cesarean section to avoid the emergency of cord prolapse, right? So that is what the RCOG guidelines says. So thank you, Dr. Anita. And now do we have Dr. Lakshmi?
Good evening.
Yes, Dr. Lakshmi, good evening. Happy to see you, Dr. Lakshmi Chaitanya. Hello. I don't think we can hear you, madam.
Ma'am, can you hear?
Yeah, right now. I can hear you now. Yes, hello. So we have this 28-year-old, fourth gravida. She has previous 3 abortions, now 39 weeks in labor, and she delivers a full-term baby. The placenta is not expelled for almost 45 minutes after birth. The placenta is not expelled, but then, she is not bleeding maybe. I will just skip these theoretical aspects later on. Now this, the healthcare worker, she gets the patient to you for further management. How will you manage this patient?
Confirm the diagnosis, it is a retained placenta as it hasn't expelled even after 30 minutes of the birth of the baby. And then we proceed, whether active management of third stage of labor is done or not, we will confirm. Empty the bladder and with catheterization is done.
Yes.
And a call for help and check for hemoglobin, and then ask for the consent and explain the risk to the patient and the attenders, and check the pulse rate and blood pressure whether it is dropping.
Yes.
And anesthetist help, we will do manual removal of placenta.
Okay. Before going for manual removal of the placenta, would you like to investigate her on some ground?
We will check her hemoglobin and then check the vitals.
Any role of ultrasound here?
In labor ultrasound.
Yes, ma'am. Adherence of the placenta.
Now that the baby is expelled, it's only the placenta, and you agree to it that it is a retained placenta. Now we have to differentiate whether it is, the placenta has got trapped, or you have to differentiate it between the morbidly adherent placenta or simple adherent placenta. So how would you do that? Or is it necessity of doing the ultrasound here?
Whether the placenta is retained, separated or not, we will check first. It is entrapped inside of the uterus. The placental vessels are invading into the myometrium of the uterus to confirm the morbidly adherent placenta.
That is what exactly I want to ask you, that, it's even if it is a retained placenta, we need to know whether it is an adherent placenta or it is a separated but entrapped placenta, right? Or maybe you can, easily do what is called as a manual removal of placenta, but for that you have to have the plane of cleavage. And for this, the ultrasonography is mandatory. Rather than just going and pulling and trying to separate the placenta and make the patient who is stable right now, we will, spoil her. She may bleed torrentially if she's got, incomplete or partial adherent placenta. Do you all agree to this?
Yes,
yes, Dr. Anita?
Yes, ma'am.
Yes. Anybody else want to contribute to this, that when you have a patient of retained placenta, Dr. Sri Harsha, Dr. Deepika, all of you are, your contribution to this discussion is welcome here. Okay, so definitely whenever you have a patient of retained placenta, you must see clinically she's stable, she's not bleeding a lot. Once she's bleeding a lot, you know that the placenta is already separated, maybe half the way at least it is separated, and then you try and manage her shock and arrange for blood and blood products, and you ask your team to arrange for the anesthetist, and you go for manual removal of placenta. But if this patient is not bleeding, that is in fact the worst point here. If she is not bleeding and the placenta is just retained inside, in spite of giving the catheterizing or emptying the bladder, in spite of giving the oxytocin, if the placenta is not getting separated, by the time you arrange for ultrasonography, see that there is a plane of cleavage. Make sure. So if there is a plane of cleavage, very good. You can go ahead with the manual removal of placenta and you can succeed. Correct? But if there is morbidly adherent placenta, the placenta accreta spectrum, whatever, accreta, increta, percreta, then definitely that is a problem, and you don't have to try unnecessarily, the manual removal also you should not go for. Now, if your patient has a good plane of cleavage, how will you go for manual removal of placenta? Dr. Lakshmi, you can continue.
With one hand in the cone shape position, you insert it into the vagina and along the and one other hand along on the fundus. The hand in the vagina, we will trace the umbilical cord and reach the center of the umbilical cord and then reach the edge of the placenta.
Correct.
And then in sweeping position, we will separate the of the uterus. And, then we will remove the placenta along with the from the fundus.
Correct. Then what will you do?
Uterotonics.
Yes, definitely. You will be. The oxytocin is already running. After you remove the placenta, you may give her methyl ergometrin. Maybe if she is bleeding and the uterus is not so well contracted, you may give her injectable, maybe the carbetocin or even the injectable prostaglandins, right? But what I want to make a point here is once you remove the placenta, you deliver it out, you have to inspect that the whole placenta has come out, right? The fetal and the maternal aspect. You have to see that no cotyledon is left out inside, no lobe of the placenta is left inside. Maybe sometimes you have a succinturate lobe, but you can make out from the cord, you can trace the membranes and see that, the whole entire placenta has come, but maybe the succinturate lobe of the placenta has retained inside. So all these things we have to take care. And then, of course, we have to manage and continue the oxytocin again for at least a few hours till everything is settled. So 6 to 8 hours at least, you have to see to it that you are maintaining the tone of the uterus and she is not bleeding, right? So these are very simple, practical things. All of you are doing this in day-to-day practice, but it's always good to revise, so that, we are ready with whatever emergency we are facing. So thank you so much, Dr. Lakshmi, for that very, detailed discussion about this retained placenta. And now we go to Dr. Deepika once again. Dr. Deepika?
Madam.
Yes. So we have this 36 weeks pregnancy who comes to you with previous normal delivery. And now she has strong labor pains, vitals are normal, fetal heart is good, cervix is fully dilated, fully effaced, and she has breech presentation. Station is at +1. Okay. Previous one normal vaginal delivery. Now full-term breech in second stage of labor. How would you go ahead with the management of this patient?
Madam, as she's as her fetal heart rate is fine and cervix is fully dilated and pelvis is adequate with adequate contractions, and I would like to go for assisted vaginal breech delivery, madam.
Okay. Do you decide that you will go for it, or you may land up into problem and you keep everything ready?
No, ma'am. I may land up in problem, and I'll take the informed consent from the patient, and I would like to arrange for the theater also, and anesthetist and neonatologist also be available at the time of delivery.
Yes.
As
So
it is a
even
preterm
if she
delivery.
has presented to you during second stage of labor, you have to call for help, all your
Help.
staff
Yes,
and
ma'am.
your colleagues, including
Yes, ma'am.
anesthetists, and you have to make sure that the relatives understand what you are going to do for them and
Yes,
how
ma'am.
stressful it is for you also. Make
Yes,
them
ma'am.
understand. Take a written informed consent saying that the patient has come to us in second stage of labor with
Labor.
breech presentation, and we will try our best. If she delivers vaginally safely, we are going to deliver her. But if she
Yes,
faces some problem, any moment we may have to go for,
to go for cesarean
yes,
section.
so cesarean section, or if at all she, even the after coming head gets trapped and all those things.
Trapped.
So maybe she have to go for, the forceps application as well.
Outlet forceps.
Yes. So
Yes,
whatever timing the patient has presented to you, what problem she can land up, all these things should be informed and written as an informed written consent at
Yes, ma'am.
admission. Even though
Yes.
I know even me as obstetrician, would you say that, my God, I will complete the paper later, let me deliver this baby first. Okay, that is our
Yes.
feeling, but sometimes that can put you into trouble.
Trouble.
Okay?
Yes, ma'am.
So on one hand, you will continue definitely. The moment you think, oh my God, breach, why she came in second stage, maybe next moment the baby will be in your hand. It will be a surprise, that is spontaneous vaginal breech delivery. Definitely, if at all you cannot, then you may have to go for the assisted breech delivery, as you have already discussed, that you may go for, you have to go for assisted breech delivery. Now, Dr. Deepika, you tell me, how will you go ahead with the delivery? All of us we will listen to you.
Ma'am, assisted breech delivery will be in 3 stages, ma'am. Delivery of breech, delivery of shoulder, and delivery of after coming head. Delivery of breech will be, it is like
whether you will give the episiotomy, we will start from that.
Sure, ma'am. Sure, ma'am. Episiotomy
Yes.
should be
So
given.
giving a
Liberal
liberal
episiotomy.
episiotomy.
Liberal episiotomy should be given
Yes.
when there is climbing of perineum. When the anterior buttock fills the perineum,
Yes.
even when the uterus is relaxed also, when there is no pushing down efforts also, even if the anterior buttock is hitching on to the perineum, then we should go for the episiotomy, and liberal episiotomy should be given. And after that, only patient should be encouraged to bear down, and hands off technique should be done, ma'am, for the anterior and posterior buttock delivery. And then followed by till umbilicus in assisted breech delivery, we should not interfere with the delivery of the baby.
Let the baby
and
deliver up to umbilical or
yes, ma'am.
umbilicus on its own. Yes.
Its own. Then after that, we should grab the baby with femoropelvic grip, warm towel with, yes, ma'am. Anterior, the back should be, we should be facing the back of the baby, and with both the both hands, we should be holding the baby, hands onto the abdomen, and onto the sacrum, we should be placing the thumbs.
Correct.
That is femoropelvic grip, ma'am.
Correct.
And after that, we should give some traction to the baby, and then
encourage her to push
push
all the
down.
time. Yes.
Yes, ma'am. And descent should be there. And then after that, the bearing down efforts should be there till we see the axillary fold of the baby,
Yes,
ma'am.
the scapula, you can say.
Scapula and axillary fold. And we should rule out whether there is any extended arms.
Yes.
And the scapula and spine,
if they are,
if
then
there is
how
any
will you
parallel,
proceed with
yes,
that?
ma'am. Yes, ma'am. And if it is an extended arm, we should go for the Lausitz maneuver, in which the baby should be rotated down and rotated in opposite direction, and make sure that posterior shoulder will be delivered, and then the anterior shoulder will be delivered, ma'am.
Yes.
And then we should go for the aftercoming head. In this aftercoming head, the most common method we follow is Burns-Marshall method, ma'am. That is delivering, yes, delivering the baby, like maintaining the flexion of the head onto the mother. We should deliver, ma'am.
Yes. You hold the ankle of the
ankle of the
and
both
here
feet.
you support the baby like this.
Like
and
this, yes, ma'am.
Take a wide arc. Yes.
Arc. Yes, ma'am. But in this technique, there will be more injuries there may be injuries for the baby. Cervical injuries can be there, and controlled arc should be taken, ma'am.
Oh, yeah, control. It
And
has to be
yes,
very
ma'am.
gentle.
Very
That is why it
gentle.
is wide arc. That means
Wide arc.
whatever it
Slow
allows
and wide.
you to do that. Okay, it's
Yes,
not
ma'am.
abrupt. It's
Yes,
a
ma'am.
wide
Slow.
arc. So that
Yes,
she's
ma'am.
pushing. The baby is coming down, and then you are taking up like
Yes,
this.
ma'am.
Okay.
And during the after coming head delivery, we should ask the assistant to give the suprapubic pressure, ma'am.
Perfect. That is what is required.
And then
Suppose
if
your head is not getting delivered by this, then what are the
yes,
other
ma'am.
techniques? Yes.
Other technique is Marcellus Milliwick technique, ma'am,
Huh?
in which we should hold the baby onto our left hand, and we should place our index finger into the mouth of the baby, and then with the right hand we should be catching hold of the nape of the neck, ma'am, and onto the shoulders also, and we should
I would
be
not say catching hold of. I would just tell you that you
just
middle
hold
finger
3
you keep
fingers.
on the occiput.
Yes,
Middle
ma'am.
finger
Occiput
you
and
put
2
on the
fingers.
occiput, push it little down that it aids flexion. Okay,
Flexion.
and then these
Yes,
both fingers on the shoulder. Okay,
yes, ma'am.
push
Yes, ma'am.
this occiput that aids the flexion further.
Flexion.
And then
Yes, ma'am.
you little hook the shoulder.
Yes,
That's
ma'am.
all.
Hook it, and this the finger in the mouth also will aggravate the flexion, ma'am. With this both the
Yeah.
movements, we can deliver the baby with
Maybe
head of the baby.
maybe we don't do that, but what I would suggest, just place your 3 fingers again, even for the left hand, 2 on the the malar prominences, okay, and maybe
Yes,
1
ma'am.
on the chin. That
Chin.
also again aids the flexion. If
Yes,
at
ma'am.
all it is getting difficult, then maybe you may have to put the finger
Put it
inside,
in the finger.
and maybe
Yes.
little traction. But putting the finger in the mouth will definitely have some injuries.
Yes, ma'am.
Yeah, that is what.
Mandibular joint injuries may
Correct,
happen.
correct.
And
Okay.
then
Even if that doesn't help, then what would you
then
do?
we
How
can
would
go
you
for
apply?
Piper's forceps, ma'am. Forceps
Yes.
application can be done.
Yes, yes. And how do
Yes.
you do that?
Ma'am,
You have the baby, then who will apply the forceps? You hand over the
ma'am,
baby.
I'll ask
Assistant.
my assistant to
Yes.
hold the baby, and then I'll go for the forceps application, ma'am.
Little up.
And then
Because
little
you
up.
you need the place there.
Yes,
So
ma'am.
the baby should be like this.
Yes, ma'am. And
okay.
I'd like to apply the forceps and maintain the flexion as it is, ma'am, for the after coming head
Definitely
delivery.
the assistant will,
Yes,
give suprapubic pressure to maintain the flexion.
Maintain the flexion.
Good. So I think these techniques. Then of course you have, even when you cannot deliver the upper arm, you go along the shoulder and you just hinge
Yes, ma'am.
the humerus. That is how
Yes,
it is.
ma'am.
And sometimes you may have that extended legs, So you just give a tap in the popliteal fossa,
Popliteal
so
fossa,
that the
and the leg
ankle
will be
comes
flexed.
down, you catch hold of the ankle and then you deliver. So that is
Yes,
what
ma'am.
the initial one difficulty what we have missed on. So I think that should be good enough for the breech delivery, assisted breech vaginal delivery. So
ma'am.
yeah, so Deepika, I'm very happy that you discussed all the techniques and all the maneuvers as well. So thank you so
ma'am.
much. And
Thank
should we go for the next case, Dr. Manasa?
Yes, ma'am.
Yes. So
So
we have
that is
34-year-old second gravida. She's got gestational diabetes. She comes in labor at 37 weeks. You find that per abdominally 36 weeks, head is 3/5 palpable, fetal heart is good, cervix is 2 centimeter fully effaced. Labor progresses normally, and after 6 hours, she's almost fully dilated. Vertex is at perineum. After 20 minutes of full dilatation, the head is delivered, but the shoulders are stuck.
So
what is your diagnosis, and
shoulders.
how do you manage? Yeah.
A case of shoulder dystocia, ma'am.
Here. Head has come, but the shoulders are stuck. And you can see the turtle, the neck like this. It has twisted. Yeah. How will you go ahead with the management? What are the do's
So
and
once the shoulder dystocia is diagnosed, first thing we need to do is, like any obstetric emergencies, call for help. Inform the people that it's a case of shoulder dystocia. Then immediately we should go for whether it is first line maneuvers or second line maneuvers, or how are we going about the case. And we can go with the first line maneuvers, that is McRoberts maneuver.
What is that?
In this,
Dr. Anita, do you want to discuss? Yes, Dr. Manasa?
Yes, ma'am.
Do you want to go ahead?
Yes, ma'am. I want to read out clearly, ma'am. So according to ACOG, it recommends that the first maneuver to be performed is McRoberts maneuver.
Okay.
In this maneuver, it involves two assistants, one holding each maternal leg to hyperflex the patient's thighs onto the abdomen by bringing the patient's knees up towards her armpits.
See,
this
we have
increases
got only one nurse doing this.
Okay.
So our patient herself will pull her legs. Maybe the sister will little, help her. It is hyperflexion of the hip over the abdomen, hyperflexion of the hip, right? What does it do? It straightens the birth canal.
Birth canal.
It, displaces the sacrum and coccyx a little behind and it increases the AP diameter. Okay, that is one. So McRoberts is leg hyperflexion. And secondly is the suprapubic
pressure.
Now I would just give any comment you want to make here on the suprapubic pressure.
To be kept in mind is avoid fundal pressure.
Okay, don't. So what is not to be done is one is fundal pressure and no traction also. Two things. Absolutely no traction, absolutely no fundal pressure. Whatever you have to do is only suprapubic pressure. Now I would come to you, Dr. Anita. How do you decide, where do you give the suprapubic pressure?
Suprapubic pressure, ma'am, the assistant or the nurse, she is facing the patient's legs and she would, with her wrist.
You tell me in relation to fetus. What side of fetus?
Over the shoulder.
Yes. The shoulder which is impacted. So how do you know that which shoulder is impacted? The occiput. Okay. The baby's occiput. You can see here. The baby's occiput is on left side, and so she's giving the pressure exactly from left side. Okay. Because the correct shoulder should be disimpacted. Otherwise, if it on the wrong side, it will not help. Right? If she gives a pressure on right side, there is nothing at the right side. Okay. So on the side of the baby's occiput. So left side in this picture. Okay. That's very, very important practical, information. Okay. So now suppose this giving this McRoberts maneuver and, even the suprapubic pressure doesn't help. Then what else you can do?
The second line maneuvers,
practical point. If
delivery of the posterior.
Yeah.
Delivery of the posterior shoulder and next going on to the rotational maneuvers.
Dr. Anita, Dr. Lakshmi, do you want to add anything here? Wood's maneuver and Wood's corkscrew and reverse corkscrew. So do not do. I have told you fundal pressure and traction both should be avoided. Purposefully, I have dropped some of the manuals because they are this is actually a panel discussion. In the talk, I have all the manuals in details, including the videos. So
from here we would like to apply the pressure over the anterior or posterior aspect of the posterior shoulder so as to dislodge it and help in delivery so that the impacted anterior shoulder will deliver later on after the posterior shoulder is delivered.
Yes, you can see here almost 3/4 of the circle.
Yes,
put your fingers in the posterior at the posterior shoulder. Okay, the posterior shoulder is little lower down. What is impacted here is the anterior shoulder. So you just put your fingers in the posterior shoulder, turn the baby almost 3/4 of a circle so that now the posterior becomes anterior and the anterior becomes posterior, and then it sleeps, it escapes. So that is what is the Wood's corkscrew maneuver. So that is a long arm. Okay. So I think should we stop here the discussion or should we continue? What is your opinion? Dr. Muralidhar Pai sir has already taken this, This is not a case discussion. I would just stop sharing, and I will just, I think we have got many emergency cases here, but I would just say that intelligent anticipation, the vigilant monitoring or supervision, the early detection and prompt management, that is the effective institution of the therapy, what we call it as timely and appropriate intervention, can prevent the disastrous consequences. And of course, not to forget the communication and documentation. So, friends, here I conclude my panel discussion by giving these simple messages. I'm sure all of you are obstetrician, though this has become, this is now becoming a dying art, delivering the babies with malpresentations and the difficulties. We are taking help of cesarean section to explain the reduction in the maternal mortality and morbidity, as well as perinatal mortality and morbidity. But definitely acquiring good skills and having a good practice will definitely save these skills which are going to help us in long term. The place of selection of cases is very important. You don't have to be very heroic to show that I can deliver breech vaginally. And that is where, though I have skipped some of the slides, because our patient has come into second stage of labor, but otherwise, if she has come to you as antenatal case, then definitely you have a scope to decide whether she should be posted for cesarean section directly, or we can go for vaginal delivery. And here comes the role of the Chartuchini-Andrews score. So how do you decide, the parity, the gestational age, the size of the baby, weight of the baby, all these things definitely you have to take into consideration. And yes, we as obstetrician should always keep learning. All of you know that obstetrics is, very unpredictable, though majority of the times you can predict, you may land up into some unavoidable or unprecedented emergencies. So we have to, predict and prevent. But yes, if you land up into such emergencies, you should be able to tackle it. And definitely counseling and documentation has got a very important role to save yourself and to your patient as well. So thank you so much. I would thank my special thanks to Dr. Shailaja and Dr. Niharika. And of course, Aruna, I can see you there, my dear. We are very happy to have
very nice panel. Very nice, very well conducted.
Wonderful panel.
And very well answered also. Very nice.
I'm very thankful to all my learned panelists who are, so good at their answers also, and whatever techniques they have discussed, it is truly very appreciable. Once again, I thank all the president and secretaries of the Warangal, Mancherial, Guntur and Kadapa societies. And I thank all the respected dignitaries as well. And I take this opportunity and humbly seek your blessings and best wishes and the wholehearted support for my candidature as Vice President Foxy. Thank you so much.
All the best to you, Sneha madam. And
all the best, ma'am.
All the best.
All the best, madam.
Thank you.
Thank you
all
so
the
much.
best, ma'am.
Thank you. And best wishes to you as well, Aruna.